Hi, Vijay.
Hello, ma'am.
Okay. No, just checking if my earphones are working properly. They are. Thanks.
Yeah.
All right. It's 2:30, so I think good afternoon, good evening, good morning, everyone, dependent on which time zone you're coming from. Welcome to all of you who have joined in for this webinar, which is part of the 9th National Bioethics Conference and the 5th Global Mental Health Summit. This year's joint and hybrid conference focuses on the theme Center Staging Human Rights, Ethics, Law, and Policy in Mental Health. And it really offers a unique opportunity for us to reflect on and to discuss priority areas in ethics and mental health. This is a very exciting edition of the conference because it's co-hosted by the Forum for Medical Ethics Society, along with leading civil society organizations such as the Banyan Academy of Leadership in Mental Health, the Center for Mental Health Law and Policy, and Sangat. I'm Urvita Bhatia. I am going to be with you throughout the sessions today. I am a research fellow based out of Sangat in Goa. The topic for our session today is research ethics, obligations in mental health spaces, an area of work which I personally believe needs to increasingly receive attention and is one of the priority areas that our speakers and panelists' work has focused on. So to briefly set context, on the first day of the conference, which many of you may have attended, we examined mental health care paradigms and we closely looked at broader issues of social justice and marginalization. We then deep dived as well into suicide prevention and as well as contemporary debates in psychiatry. Today, we'll hear about neglected perspectives in ethics and research and understand what it truly means to be participatory, for instance, to meaningfully hear, involve, mobilize, as well as impact representative populations in clinical and community research. Our hope is that we offer a space for critical reflections and discussions, as well as debate, and leave you with many answers, but also many more questions on the intersections of mental health, human rights, and ethics. In terms of today's format, we have a good range of sessions from keynote addresses to panel discussions from 2:30 p.m. to 7 p.m. IST. And over the next few minutes, we will first begin with the keynote address. In all of the sessions that you hear today, we'll hear about the current work of the speakers, as well as learnings from their body of work. And we'll also learn about innovative approaches in ensuring good ethical practice and opportunities to reconceptualize ethics and research in low resource settings. Just a few housekeeping announcements. Just a reminder to keep the questions coming in. You'll find the Q&A tab, which will be reviewed by our team and by the end as well of the speaker remarks. We will take these questions. Feel free to also leave in any comments on the chat box for the speakers as well as the organizing team. And in case you're posting about this session on Twitter or on Instagram, please use our handles to tag us. This includes the Indian Journal of Medical Ethics, CMHLP India, BAM Academy, and Sangat India. With that, we'll begin our first session for today, which focuses on how good and responsible science must protect the rights of people it serves. I'd like to invite Julian Eaton for the first session. To briefly introduce Julian, Julian is the Mental Health Director for CBM Global and is an assistant professor at the London School of Hygiene and Tropical Medicine. He is a public health psychiatrist focused mainly on improving access to care and support in low and middle income countries. He works with a team providing technical support for CBM partner programs around the world, covering long-term development and humanitarian emergency settings with a focus on inclusion as well as right-based approaches. With that, I welcome Julian.
Well, good morning from me, but I'm aware that most people probably, it's not morning, but it really is a demonstration of the wonders of technology that we can be meeting together now to think about this incredibly important topic. It's really a great honor to be invited to speak to you today. This is a topic that I've been giving a lot of thought to in recent years. And I'm ashamed to say that during my training, both in psychiatry and early parts of my research training, there was very little thinking done about the participation of people with experiences of the types of issues that were being researched. It seems so incredibly obvious, and yet it's something that I think is in its very early years of really exploring in depth. And this conference has been a great opportunity to do that for all of us. So let me start by just sharing a little bit about maybe the history of where we have come from in this area. I'm going to start in 2007, not because history started in 2007, but because that's when there's an important coming together, I think, of our field, our new field of global mental health. And importantly, it's always been an action-orientated field, defined often as a field of research and practice in public mental health. And the big announcement, the big call for action at the end of that initial meeting that was held to launch a series of papers exploring this area, which was really a foundation of where we planned to go, was a call for action to scale up coverage of services and to strengthen protection of the human rights of people with mental disorders. Now, I don't use the term mental disorders very much anymore because I think language is part of the problem. The way that we speak, especially the way we speak about people, really betrays the foundations of where we're coming from. And I think words are very important, and words like disorders tend to separate people, put them down, define them in certain ways. So that's just one flag at the beginning, that as we work in this area, we always have to be very conscious of our words. But this is a positive thing. At the beginning of our field, as I said, of course, there's been lots happening before that, but of a new field, of a new area of thinking, we thought about human rights. And it was seen as important because often this is an issue that has been a shame to our sector, a shame to people who are seeking to provide support for people with mental health problems, is what has been done in the past and what continues to be done, both in environments of families and in communities, and also the places where people should be getting help and support, including from professionals in mental health and from governments who have a responsibility to look after and support people. On this slide, there is a image of some children. These children are in Ghana, in West Africa, and they're holding up a sign that says, "We are not witches or wizards." I put this picture up because it's one of the examples of these kinds of abuses that are often very stark, especially with people who are homeless, for example, with quite severe and enduring mental health problems. But these are children whose behavior has been seen as unacceptable within their communities. And rather than there being a sense of understanding where their behavior is coming from, maybe it's because of social determinants, maybe it is because of a mental health problem, they are outed. And cultural background is often a part of why people are thought about in certain ways. And some of these children are terribly abused because of being thought to be possessed. Moving on from that first launch of a sense of not only treatment being made more available for people, and the field has been really focused on treatment for a long time now, but that human rights was central as well, was a series about 4 years later in 2011 that had as one of its key papers, one of the important papers, the human rights of people with mental health and psychosocial disabilities. But I missed out one word there, and that word is violation. So the focus still, 4 years later, was on abuse of people with mental health problems and psychosocial disabilities. The reason I really want to point this out is because this is one of the issues that has been very central to the critiques of global mental health. That while it's recognized as a very positive thing that human rights are being talked about in our field from the very beginning as a central thing, they continue to be mainly focusing on people who are being abused, rather than looking in a more broad way about the positive way that people should be participating in society. So that whole other dimension of the rights that people have to live in a way that's equivalent to everyone else hasn't really been sufficiently emphasized. And certainly the disability movement has felt that quite strongly about our space. And it's really the Convention on the Rights of Persons with Disabilities, which was eventually brought into law internationally in 2007, that shifted that. Of course, there are some things in there about protecting people from abuse, but the overall theme of the Convention on the Rights of Persons with Disabilities is we have a right to be treated like anyone else in the positive things we all enjoy, in our family life, in our right to participate in our communities, in our right to have voting rights, and positive things that enable people with disabilities to contribute to the broader field. And this is a foundational document for our space as well, because historically, the disability movement has really been around physical disabilities and around sensory disabilities. And maybe intellectual disabilities had been there, but always actually a very neglected area. But it was with this document that the movements of people who've historically fought against psychiatry because they felt terribly abused by psychiatry, by efforts to support them, became a part of the fold of the global disability movement. And I think that really transformed our relationship as a health field with people with disabilities, people with psychosocial disabilities, people who have a self-identity as a person with a mental health problem, but who does not want to be defined as a person just with a diagnosis whose only way of being thought about is as a person receiving treatment. Rather, they became people who wanted to express that desire to be a full person, recognized in the whole way that they could contribute to society, and being deserving of all the rights of people in society. So, having said all that, I am going to start a little bit with the way that psychiatry and mental health services have treated people. I'm not going to dwell on this in any great detail because I want to move on to solutions. But just to say that globally, in every country, there is generally a very bad history of treatment. There are also some very positive things. So the asylum movement in the UK started as a way of trying to support people with positive environments in which they could heal. There is a hospital in Baghdad, which some people would say is the oldest psychiatric hospital in the world, dating from the 13th century, which was primarily about giving people a peaceful and serene and pleasant environment in which to improve, in which to deal with the mental distress they plainly had. But unfortunately, there are a whole litany of examples of terrible treatments being provided for people. This is an example of a water treatment that's provided, of warm baths for people. But there's, as many of you will know, people who've had undergone terrible surgery, for example, or very debilitating medical treatment like insulin coma therapy, people who've had to endure holes being drilled into their head, all sorts of terrible things. And the reason I mention this is because we would never, ever consider doing this to people who we considered to have a view about what was being done. People often participated in this because they were desperate, they were looking for a solution, but because the power relationship between them and the medical establishment, or the traditional healer in some countries, or a spiritual healer in other countries, the power imbalance was so big, and there's assumption of science or spiritual solutions or traditional solutions being so important and right, that people were willing to put up with being treated terribly. So that's in health, that's in services for trying to improve people's well-being. Unfortunately, in science, similarly, terrible things have been done to people in the name of science, in the name of trying to find solutions to make them better. Now, sometimes that is just an outrageous ethical disaster. For example, people being used for experiments in Nazi Germany, or in the southern parts of America during what was effectively apartheid. And that has been rightfully shamed, and many of the ethical codes that we now use came directly out of those abuses that were being perpetrated on people then. But I want to suggest that bad science is also an abuse. If we don't properly have a good sense of the needs that people have, their priorities, then we end up asking the wrong scientific questions. And then we start doing science that might be good in its method, but it's a waste of money, it's a waste of resources, it's a waste of everyone's time. And more importantly, it puts people through a process, even if it's the inconvenience of filling out a survey, but sometimes it's having medicines tested on them and more serious interventions that shouldn't have been done in the first place. So what I'm going to talk about for the rest of my talk is really about how we can get out of this terrible history, how we can reshape things so that we don't make the same mistakes as in the past. And my contention is that the way we do that is proper, meaningful participation of people with lived experience. I'm talking particularly here about services research, which is what the field of global mental health is particularly interested in. Remember, its first call to action was about improving coverage, and that coverage must be of helpful, useful things that make people better. I'm not necessarily talking about all lab science and other science, but particularly services research is very important. I would say that the basic theoretical research also needs to have a strong steer from people affected with these conditions, again, because they hold expertise that scientists who have never had the experience themselves might not hold. So this is a great opportunity. This mantra of the disability movement, nothing about us without us, I think is the way that as a field of global mental health, we can restore the right relationship with the people we seek to support. It's one of the unique things, particularly about psychiatry, I would say, that we have more power in law than any other field of medicine, apart from sometimes very severe, extreme public health emergencies of infectious disease. But generally, in mental health, we have far more power to treat people against their will, for example, to make decisions that aren't centered on what that person wants. And that has harmed us, I think, as a field. And we need to reclaim the fact that we primarily came into this to be therapists, not to be pushing people into doing things they don't want to do. So what might the benefits be to science if we do this properly? First of all, as I mentioned earlier, at the basis of all good research is a good question. And if we're going to use our resources well, if we're going to use our careers well, not waste our time, not waste everyone else's time, we need to be concentrating on the important things, on the right questions. And those questions are only going to be properly asked if we have a good sense of what the priorities are of people with lived experience. Secondly, people who are carrying out research inevitably have all sorts of biases. They have all sorts of preconceived ideas and stereotypes. And that shapes in very subtle ways the way they do research, the way they ask questions, and the way they interpret the data that they collect. And a proper grounding in a sense of what the reality in the field is makes it much less likely that those biases of people who don't know very much about what they're researching about, in fact, often, those mistakes are less likely to be made. Thirdly, and I know that you're concentrating a lot on ethics, but I'm not going to really concentrate on this particularly, although of course it's an overarching theme, is that it is increasingly indefensible to carry out research where the people who are going to be affected by that research are not properly involved. That's exactly as it should be. These are really important ethical frameworks that are now being strongly put in place. And if you're going to do good research, you need to defend it ethically. And for a wide range of reasons, I'm sure you'll be hearing about during this conference, it's ethically much more defensible to be including people with lived experience. I've already mentioned, I think it's just much less of a waste, and you're going to have a much greater impact if the questions are good and if the methods used are strong in terms of their level of participation, because the results are going to be better. And it's not only that the results will be better, there'll be a greater sense of ownership over those results, and the recommendations that come out of them are much more likely to hit home, to be used and to be taken up. But in a systematic review in 2016, for low and middle income country, my colleague, Maya Zemrau, only found one paper that involved people with lived experience in mental health research in a systematic way. Now, I think this is probably because we were focusing particularly on published research in journals and peer-reviewed journals. And there's a lot of good practice out there that doesn't necessarily come into this relatively narrow area of published research. But it's shocking how bad it has been historically. I have to say, I think it's getting much better, and I'll get onto that in a second. It's not all doom and gloom. There are a few ways that we can try to improve this situation. And the first, which you might not think is a method, is consent. Because I would say this is the first level of involvement, and actually one that's been accepted since those foundational principles of ethics in research were laid down in the 1940s and 50s after the abuses of the Second World War. And that is based at present, in the great majority of cases around the world, on this idea of mental capacity, which is obviously very important for us in mental health research. One of the things that's concerned me for a while is that when I'm reviewing either ethics applications or research proposals, I often see, even in research, let's say that's about depression, that people with severe mental illness who might not be able to give capacity are excluded from that research. My concern then is that whether it's research about other mental conditions or about physical health or other research, we know very little about that particular group of people. So the risk of having mental capacity as a kind of central principle in consent is that we're not learning very much about that particular group of people who are seen as not able to give consent and therefore are routinely excluded. A little bit like the fact that the great majority of medication that is used around the world has never been properly tested on women of childbearing age or on children. And so we're guessing when we use those medications on those group of people who've never been really properly involved in the science of discovery around how those molecules work. Of course, I'm not suggesting that mental testing and understanding mental capacity, people's ability to properly give meaningful consent is not an important thing, but I think it raises some important questions. And in this particular section, I want to say to you that I'm not sure of where exactly the answers are, but I think we need to explore some of these issues. The alternative way of thinking about consent is the way that the Convention on the Rights of Persons with Disabilities thinks about it. And that wants to move away from this idea of mental capacity, which apart from in this area of research has often been used as the reason for the state taking over the right to treat someone against their will. I want to move away from mental capacity to legal capacity. The fact that people always have rights, whether or not they have mental capacity, they always have rights. And that's a really foundational principle. The question is, how does that apply to those of us who are thinking about research? Because legal capacity is normally thought about as a kind of fundamental principle to avoid coercion in treatment. But people aren't forced to do research. It's something that they might choose to do to benefit wider society. So there is an idea of the will and preference. Would this person likely want to participate in this research? Is it something that they are likely to want to do? And we think about doing that through a process of supportive decision making. So whereas deciding someone doesn't have mental capacity and therefore either can or can't make a decision, that's often called substitute decision making. We need to move towards a situation where we come alongside people and work in an honest way to understand what their particular preference might be. And I think, of course, it depends on the level of intervention, the risk of harm, for example. But I think we should be thinking much more in this broader way about how people with mental health problems participate in research. Is it what they want to be doing? And thinking much more about their positive rights rather than just about mental capacity. The second major method, and this is something I'm sure you'll be hearing much more about, is co-production. Now, this is a word that has been used to mean slightly different things, and I could have listed 8 different definitions of co-production, but I think it's a bit like stigma. It's one of those words that if you try to define it in a very detailed way, you need to write a PhD, but actually everyone understands. And the principle of co-production is working together for an outcome, rather than having one person doing something for other people who don't have any say in it. And there are some major principles that underlie that. First of all, equality, that basic recognition that there are experts by profession or by being scientific researchers and methods, but there are also experts by experience. And those are equally valued things, assets that people bring along to the relationship and the process or the piece of research. That we recognize and appreciate diversity, and diversity of voices strengthen the work we're doing together. That we often need to work in practical ways to make sure people who have relatively less power can participate, and that those people could also benefit, must also benefit from processes of research, which have historically benefited researchers, their careers, maybe their chance of getting a future grant, but not really the people who've invested time and energy in participating in research. And that the other foundational principle of it is that you cannot do it as an afterthought. It must be right from that research question fashioning, right through thinking about how methods are going to be applied, right through the process of analysis, and right into thinking about the conclusions you draw from the results. And the third method, which I'm not going to talk about at great length, is participatory action research. And this really takes research into the field. And it recognizes that whereas sometimes those of us who are very immersed in research and spend our whole lives doing research, we can only think about research for research's sake, whereas actually it must be rooted in changing the world. It must be rooted in the impact it's likely to have. And again, I'm really talking mainly about services research. There are, of course, reasons to examine the inner workings of the atom, which might not have very immediate application. But here we're talking about ways of doing this research that feeds into the field of global mental health. So this cycle, not just of a short-term project that starts and finishes, but that we're working in a broader process of bringing about change, of including people in that process of bringing about change, and that research is a part of a bigger movement than just research for research's sake. As I said earlier, I do think we're getting there. There has been, I think, a revolutionary change, even since that 2016 systematic review, in the degree to which it's accepted at the highest levels that people must be involved in research. Now, some of these high-level documents I'm talking about here, the Convention on Rights of Persons with Disabilities, the Sustainable Development Goals, the Mental Health Action Plan of the WHO, are not just about research, but this principle of people being involved in processes that affect them is both about research and about services. So that's accepted at the highest levels. I submitted a paper very recently to the British Medical Journal, and in order to get through the submission process, I had to state how people with lived experience had been involved in my research. And I actually would not be able to submit it both without that statement and a statement positively stating that I had. That it wouldn't be possible for me to submit research without stating that people had been involved in the process. So journals often have those policies. And the process of research ethics applications for successfully applying for a grant also often involve demonstrating how you are going to include people with lived experience, with patients, clients, people with an interest in this area are involved. And that means it's incumbent upon all of us who are researchers to get good at this, to learn how to do it well, to speak the language well, to really understand how to describe to people who are considering our applications that we really know what we're talking about, and we're going to do it really properly because of some of the challenges that there are out there. The first and main one, which you will be aware of, is the whole issue of power and status. The reason why people have put up with the terrible different types of treatment that have been given out in the past and continue to be is because of power. And that continues to dog this area where we are trying to involve people who, in general, in most societies, have a low status, alongside doctors and professors who generally have a very high status. How do we get around that issue of power? And we need to think about it very carefully at every level. Tokenism is also often seen as the big challenge, where the risk is that once the Global Mental Health Action Plan says that we need to involve people with lived experience, they get invited to meetings, but there's no meaningful participation in that process. And people have often talked about really needing to build over a long period of time people who are confident enough, knowledgeable enough about research to be able to speak into spaces that otherwise they're very excluded from because of jargon and acronyms and not being given time to understand the process properly. And that's this accessibility, people's ability to be given the space to, for example, being given things to read in advance, or having a session with the researcher where they can ask questions before the high-level research ethics review, for example, in what can often be very intimidating environments. So really practical things is what makes the biggest difference. Just as I draw to a close, I want to give you an example of some of the research that we've been doing in a very co-produced way. And in fact, I'll briefly advertise here that our online course and co-production is going to be out in the middle part of next year, that comes from this program. Succeed, which is support, comprehensive care and empowerment of people with psychosocial disabilities in sub-Saharan Africa, is a 6-year program funded by the UK government, where a team at London School of Hygiene, in which I work, and in 4 African universities in Malawi, Sierra Leone, Zimbabwe and Nigeria, are looking at a way of supporting people with severe and enduring mental health problems in communities to live full and rich lives in their own communities. But the foundational principle of it is we're doing the whole thing through a very co-produced process. So just some of the things that we're doing in order to try to realize that. First of all, is that from the very beginning, we had a lived experience advisory panel. So people with the types of conditions that we're interested in researching were involved in the process of developing the research in the first place, and continue to be an integral part of our governance. So whenever we reach an important milestone, for example, we want to submit a protocol for our ethics, the lived experience advisory panel reviews that alongside a scientific advisory panel. In every one of our sites, we have peer researchers, so people with research skills and who have a lived experience of psychosis in our case, who are part of the team and are involved in every part of the process of developing the work that's going through. In each country, we engage really closely with organizations of people with psychosocial disabilities to make sure that we understand the context and their experience of living in those communities where we're going to be doing the work very well. So these are very practical ways that research can be better at listening, but I don't want to suggest that this is an exception. These types of practices should be a part of all research. And I'm really delighted to say that one of the biggest successes, I would say, of this program so far has been the number of other research projects that we've collaborated with to help them to instill some of these ideas into the way they're doing things. So I do think this is a magic bullet. I think that we have this history that is unfortunate. We shouldn't bear the burden of that, those of us who are trying to work now. But it is incumbent upon us to change it, to find new ways of working that are more respectful and thoughtful and will result in better science. Thank you.
Thanks, Julian, for that very exciting talk. I think you very neatly covered historical as well as contemporary perspectives on the rights of people with mental health problems in the context of research. I do have a few questions, but I will first request you to take the questions that the audience have put forth. So I will read these out. Aruna asks, you mentioned the use of the term mental disorders, which might be discriminatory. How does this thought translate into mental health vocabulary that is not in English, which might be related to the societal medias in the global South? Is it possible that terms that equate mental disorders in languages other than English might be practical ways of classification rather than falling into the realm of discriminatory language? Thanks.
You've touched upon a huge topic here. The last slide I showed talked about rebalancing power in global mental health. That process that we underwent at London School a couple of years ago is partly about rebalancing power in relation to people with lived experience and researchers and practitioners. It was also about rebalancing power in the global North and the global South. And a whole area of our challenge, I think, in research is this fact that much of what is practiced globally now comes from a colonial history. And I think that we really need to refashion global mental health in a way that starts much more in understanding how languages work in the particular place we're doing any research. I think it is very likely that results will be almost worthless in many cases if we try to do things using English language in places with people who don't primarily speak in the English language, and we need to start from the bottom up. So I do think that in answer to your question, of course, the local milieu is completely central, and there's some really good examples of research that's been done, or really is a process rather than the research itself, that starts by asking, what are the languages, what are the words that you use to describe these issues, and start from there. Now, very sadly, in my experience, where I've been involved in this a few times, they are almost always pretty discriminatory words. It's around madness and craziness and possession. But I think that's often because the major archetype of what people think of as mental illness is severe mental illness, people who are very clearly unwell on the streets, sometimes chained up in communities, for example, which is highly stigmatizing and othering. What I think makes the difference is when you say to those same people, I'm not only talking actually about those people who you see with very severe problems. I'm talking about distress. I'm talking about daily worries that we all have. And that brings it into the realm of something we all own. So usually you end up with these two baskets of words. You have the ones that are around severe mental illness, which is often very discriminatory and often very nasty and abusive. The terms of abuse used in the communities. But you also have this set of words that are much more about bringing people alongside and supporting people who are currently going through a difficult time. And I do think it's possible to use both of those words, but to bring that sense of it's not only severe mental illness we're talking about something we all go through as well. And that can be a much more inclusive set of words. I could talk about this for a long time. I will stop now, except to say there's a whole very interesting area of efforts to change words. So, for example, in China, really important work was done about epilepsy, where the word in Chinese for epilepsy was around spiritual possession, or even being like an animal. And a process was carried out of inventing a new word. Let's think of a new word that's better, that defines what we're talking about in a much more accurate, but also less discriminatory way.
Right. Thanks, Julian. Another question. This is by Purnur. I came across a public health survey assessing suicidal ideation, hopelessness in elderly in an area with per year suicide rates. Methodology mentioned waiver approved by university in line with the Helsinki Declaration. Can you please explain a bit about special scenario consent waivers?
Yes. So this is typically done. Let's think about the most extreme example. Let's say people who are in a coma. People who are in a coma are not able to give consent. And we really need to do research around people who are in comas. Otherwise, we'd never learn how to treat people better in that situation. And therefore, it's accepted by most people that comes back to what I was saying about will and preference in the Convention of Rights of Persons with Disabilities. That person would probably want to participate in research, and the consent is acceptable from another person, usually a family member. Now, sometimes professionals are allowed to participate in that kind of waiver process, and it depends on the level of intervention. And if you're going to be causing people pain, you're very unlikely to be able to get to do that. But it has and can also be applied to people who are not unconscious, but are not judged to have mental capacity, again, because it's really important that we do research. So children, for example, might not be seen to give the same, be able to give the same consent as an adult, but with their parents, they're able to do that. People with dementia, for example, again, might be seen as able to participate to a level, and a waiver is given for someone else to make that consent. Now, I would argue that that is best done underneath this umbrella of the Convention on the Rights of Persons with Disabilities, still seeking to provide supportive decision making, understanding what that person would want. For example, asking people who knew them before, rather than only making a decision on their behalf because of the nature of the situation. We should still strive to understand what that person's will and preference would be.
Right. Thanks, Julian. The next question is, how do you ensure people with lived experience are involved in research papers, i.e., does it have to be a declared diagnosed disorder? Does a piece of research have to involve beneficiaries?
I mean, the short answer is that, yes, I think research should involve beneficiaries, unless there aren't any clear links with beneficiaries in the research. So I gave the extreme example of research about the inside of an atom. And there might be some parts of mental health research that's very biological, for example, but I would still say it's helpful to shape the direction of research. But certainly any research that's around services, around interventions where people are involved, yes, I think they should be involved, and I don't see any reason why they wouldn't be. When you talk about whether people have a declared diagnosis, that is a fascinating question, because one of the issues that people often have in the disability movement is they don't want to be defined by that diagnosis, and so you end up in a situation where self-declaration, self-identity is where people are comfortable with participating on the basis of them saying, this is where I define myself in this. And that can be problematic if you're doing a randomized controlled trial where a particular diagnosis is an essential component of participation in that trial. So that can be an issue. But I would say that generally, if you have a way of inclusion-exclusion criteria, people who fit into your inclusion or exclusion criteria are your participants. They should be involved, and just by becoming a participant, they're kind of declared already. But you're absolutely right. We shouldn't force people to declare or to accept a diagnosis before they can participate in research. So the specific participants, it's usually pretty clear. But for example, on your advisory panel, you wouldn't necessarily force people to be declaring having a diagnosis in the same way as you might for your research participants.
Thanks, Julian. I forgot to mention the name of the participant. It was Shreya, who also commented that BARM, which is the institution that she perhaps works in, engages in participatory research with people with lived experience of homelessness and mental illness. And she does hope to work with you in the future on this. Right. So we actually do not have time, and we have quite a big question. Just wanted to see whether you'd like to take it, which is an anonymous person would like to ask, how does one decolonize mental health?
I think that should be the theme of your next year's conference, because I'm not going to answer it in 1 minute. The only thing to say is that these two things are intimately connected, because they're about power, they're about voice, and that sometimes is voice that's based on coming from a part of the world that hasn't historically set the agenda for global mental health, and sometimes it's because of an excluded group, like being a person with lived experience. There are other marginalized groups. Women haven't historically had enough voice in these things. So I think a lot of the methods, a lot of the principles actually translate across these different areas in making our research better and more diverse and more participatory. But I'm not going to go in any greater detail than that, I'm afraid. There just isn't time.
Right. And as you said earlier, you require perhaps to do a PhD on this to be able to give this
Yes.
sufficient depth. Right. So thank you, Julian. With this, I'd like to end this session. I just wanted to say that I really like that you moved beyond discussing problems to actually finding solutions that we can use in real practice. We understood what bad science is and how that constitutes as abuse. And also, it was good to learn about what good science looks like. It's about asking the right questions, not being wasteful, as well as, most importantly, looking at ownership of the research process as well as results of research. So with that, we'd like to close this session. Thank you very much for joining us despite being jet lagged. And for the rest of the participants, there's a 10-minute break now. And when we're back, we will be entering the panel discussion, which will be moderated by Sunita Bandevar. So I'll see you all in 10 minutes. And thank you very much, Julian.
Thank you.
Bye.
Bye-bye.
Hello, everyone. Apologies for the delay. We were just hoping to start the panel discussion after all the panelists have joined. But we're going to try something new today, which is we'll have the first panel discussion in the... Okay, I'm not sure if I was audible earlier, but I just wanted to apologize for the delay. And we just wanted all panelists to join in. We will start the panel discussion, but with a change. We're going to have the first panel discussion, I think, in the world where we have a single panelist. So very excited about that. We'll keep the discussion going. We'll look forward to many questions in the Q&A as well. And with that, I'd like to invite Sunita to lead this session. This session is on collaborative mental health research initiatives involving communities navigating through ethical dilemmas. To briefly introduce Sunita, Sunita has training in anthropology and bioethics. Her engagement with health as a field of inquiry over the past 30 years is primarily via empirical research and advocacy in the areas of women and health, bioethics, and global health. She is a General Secretary, Forum for Medical Ethics Society, and heads its newly established programmatic platform, namely the Health Ethics and Law Institute for Training, Research, and Advocacy. So I welcome Sunita and I welcome our key panelist, Marisha.
Thank you, Urvita. And well, some of these kind of challenges. Am I audible?
Yes.
Okay, great. So thanks, Urvita. And I think we'll be sometime there are privileges because we may have more time for discussion and we can get Julian back to respond to some of the questions which we could not take up. So that's the advantage. And I'm still looking forward to having Lola and Atula to join us. So once again, good afternoon. A warm welcome and greetings to the esteemed panelists and Marisha, basically you. On behalf of the organizing committee and the co-host of the 9th NBC and 5th Global Mental Health Summit, this is 45 minutes long session on one of the most important thematics in the contemporary context of ever-increasing multidisciplinary and collaborative research, namely collaborative mental health research initiatives involving communities. And we are going to look at some of the ethical dilemmas therein. So we are privileged to have speakers, and we hope that we'll have other two speakers joining in. And they have wealth of expertise and experience of working on the ground in resource-limited settings from the global south, and the same time with the deeper engagement with global mental health spaces. And together they will be covering quite a ground on the theme of the session as reflected in the thematics of their talks. Over the past 3 decades, there is substantial scholarship that has evolved on the theme of collaborative research ethics to the extent that it is now one of the niche areas within the research ethics discipline. As many would appreciate in the audience and in the as panelists, the very nature of research enterprise, and we've heard so much about that from Julian, that the enterprise consists of various stakeholder of constituencies, and the relationship amongst them, which are asymmetrical, loaded with power asymmetries across various axes, such as access to knowledge, not so much about the expertise per se, and resources on the one hand, and much more complex relationships or lack of relationship with study participating communities. The discourse on collaborative research ethics is rooted in the recognition of these inherent complex inequities amongst research stakeholders or constituencies, and it responds to address them through normative research ethics discourse, and also attempts to develop various operational tools and guidance with the hope that these imbalances in the relationship can be taken care of. To my mind, it is 90s or early sort of late 80s with the advent of international HIV/AIDS research that necessitated to engage with these issues, center staging communities and researchers from LMICs. The overall structure of this session, and I'll sort of, we were thinking that we'll have 3 back-to-back presentation and we'll open the floor for conversation. Now, since we have only Marisha with us, I'm going to really start with with Marisha now. So Marisha, welcome again. And I'm just going to do a bit of your introduction. I'm sure that audience has been reading through the bio sketches that are available on the website. So Marisha, researching the ethics of involuntary admission and that's her topic of today's talk, researching the ethics of involuntary admissions and democratization of access to care, walking a tightrope. Marisha is a bioethicist and qualitative researcher with a doctorate in population health from University of Oxford, where she studied ethical considerations in decision-making for involuntary psychiatric admission. Her interest areas include mental health care ethics, research ethics, and harm reduction ethics. She currently works as a research fellow at the London School of Hygiene and Tropical Medicine. And in this role, she led the development of a clinical guideline to improve access to opiate substitution therapy in acute hospital settings. Earlier, as a research associate at the Kennedy Institute of Ethics, Georgetown University, Marisha worked to develop ethics guidance for the responsible and equitable inclusion of pregnant participants in clinical research. With that brief introduction, and she has a lot to her profile of the work and the contribution she has made. And I'm particularly delighted because we are being in bioethicist kind of space, bioethics spaces. I know the community at ETHOC Center, and we have friends there who also did the DPhil. Marisha, you're senior probably. And so I'm particularly delighted to welcome you here. So over to you, and you probably have a little more time because otherwise I was just going to allocate 10 minutes to you. So have a little more time, and then if we don't get our other friends on board, we'll open it for the conversation with the audience, and probably we can also have Julian back in the conversation. Over to you, Marisha, please.
Great. Thank you so much for that really generous introduction, Sunitha. Really appreciate it. So I'm really, really honored to be here. I'm just going to, as always, do my best to share my screen and probably not succeed. Can you all see those slides?
Yes, we can.
Excellent. Okay. All right. So, and I just want to kind of preface what I'm going to say in that obviously I had kind of planned my talk around the presentations that Lola and Atala were going to give as well. So hopefully they can join us. But just to acknowledge that I'm going to address, one very, very small piece of this puzzle, which has to do with actually weighing up the influence that the health system itself has on the kind of research activities that we do, and ultimately on clinical practice. So I'll just open with that. So as Sunitha said, my name is Marisha Wickramasinghe, and today I'm going to talk to you, as I said, about the kind of the relationship between ethics and the health system. And I'm going to do that using some of the research that I've done around involuntary admissions decision-making in a context of expanding access to mental health care. So first, and a little bit unorthodox, but I'm going to start with the key takeaway. So, if you zone out in the next 10 minutes or so, this is what you need to know. So I'm hoping to convince you today that the extent to which we can make ethical decisions in clinical contexts, if at all, is inevitably going to be constrained by the health system structure. And if that's true, or if I can convince you that it's true, this would apply to not only medical practice, but also to health research. And of course, that's the kind of driving message I want to deliver today. And we'll talk more about that as the talk continues. So keeping that in mind, I want to kind of set the scene for our case study. So as this entire audience will likely know, involuntary admission is a widely contested medical practice in mental health care. It is indeed outright prohibited in the CRPD. Yet the practice is still legally permissible, at least in some form, across most jurisdictions globally. Now, for the purposes of this presentation, I'm going to set aside that foundational ethical debate, right? Not because it's not important, but because my starting point is the fact that, whether involuntary admission is or is not, it should or should not ever be ethically permissible. The fact is the practice remains both common and legal across most contexts. And to note, in its kind of strictest definition, where involuntary admission is any admission without consent, this would also apply to what is commonly referred to as emergency care, right? Emergency mental health care, usually for 24 to 72 hours, and that's what I'll be talking about in this particular talk today. Now, just as a refresher, though I doubt many of you need it, legally, largely to kind of curb the paternalistic powers that may be, involuntary admission is usually only permissible under certain criteria. So for example, when an individual poses a risk of harm to themselves, when an individual poses a risk of harm to others, where an individual may be deemed to lack capacity, or some combination of these criteria, right? So we know this is a really contested topic. We also know that practitioners are given specific criteria to make these contested decisions. But what happens when the rubber meets the road? And what I mean by that is, how are decisions made in real time on the ground? And the even more tailored question that I think we have to ask in global mental health is, how are involuntary admissions decisions made in contexts where key tenets of the field have been taken up? And by this, what I'm referring to is the widely promoted model of service delivery within global mental health. So this image will look really familiar to many of you. Global mental health has widely promoted expanding access to mental health care by integrating mental health care delivery into general healthcare delivery. And with good logic, right? If you'd go to your local hospital for a stroke, why wouldn't you go to your local hospital for a mental health crisis? And what you'll notice is that a key aspect of this service delivery model is the provision of inpatient psychiatric care in general hospitals, which necessarily includes involuntary admission. So I wanted to understand how these decisions are made in context, right? How these decisions are actually made on the ground. So where involuntary admissions occur in general hospitals and most often are made by non-specialist practitioners. And one context where the health system kind of mirrors this setup is South Africa. So South Africa's Mental Health Care Act, which was written in 2002 and adopted in 2004, broadly outlines a health system structure that aligns with WHO's service provision pyramid, at least with respect to hospital admissions and the inpatient mental health care system. Now, in this system, people are first admitted, whether voluntarily or involuntarily, to a general hospital to receive psychiatric inpatient care. After 72 hours, patients who are involuntarily admitted are then reassessed for referral to the psychiatric hospital. So to get a better sense of how these decisions are made, I interviewed mental health care practitioners as well as mental health advocates to explore decision-making in practice. Now, what I learned might not surprise those of you who make clinical decisions of this kind on a regular basis, but to be honest, I was pretty blown away. So yes, practitioners do use legally prescribed criteria, right? Is this person likely to hurt themselves? Is this person likely to hurt others? Which, just to say, are also kind of widely contested risk determinations themselves, notoriously subject to sort of prejudicial views and so on. But I'll leave that to say that what struck me the most is that practitioners are also weighing up a range of extra legal factors, primarily with respect to the health system structure itself. So practitioners reported making their admissions decisions based on whether there might be the possibility of referral. Practitioners reported making decisions based on whether the admitted individual might have access to specialist care in the general hospital, whether because there is a specialist on staff, or because the specialist might have have a visit scheduled to the hospital later that week. Practitioners also reported making decisions based on their own view as the practitioner and as the decision maker about whether or not the patient could benefit from being on a general as opposed to a specialist ward. Now, just to say, in the interest of time, which we actually have a bit more of maybe, but I do have some quotes at the end of my slides if folks are interested. But yeah, I'd be happy to discuss further if anyone would like to know a little bit more about how practitioners and advocates were talking about these kinds of things. But in summary, the point is this, right? Clinical decision-making on an already ethically contested topic is further impacted, at least in part, by the health system structure itself. Now, that might sound an obvious point, but I think it has really salient consequences for not only clinical practice, but health research. So what can we learn from this? So firstly, we cannot shy away from the reality that the health system, how it works, how it's structured, how it's funded, has an inevitable impact on how already ethically contested decisions are made. And secondly, for those of us working in global mental health, we have to accept that the standard model of service delivery we promote, where mental health services are made more accessible via general hospital, brings special considerations, if not specific consequences, for decision-making about involuntary admissions. So in closing, I want to reiterate the point I made at the start of the presentation, which is that we have to recognize that the extent to which ethical decisions can be made, if at all, depends not only on what we normally consider to be relevant, human rights frameworks, legal instruments, and so on, but also on the very nature of the health system and how it works. Now, in clinical practice, I think that means we need to acknowledge the outsized effect that the health system itself can have on decision-making. And critically to this talk, in health research, I think it means we need to be sure that we're starting to measure, or at least approximate, the influence of the health system's structure on how decisions are made, both by the practitioner and the potential patient. So I will close there. Thank you so much for your attention. And I'm really looking forward to the discussion, which maybe is about to begin. But again, the kind of key takeaway here is just to acknowledge that when we're talking about collaborative mental health research, we talk a lot about individual stakeholders' involvement, but there is this kind of arguably elephant in the room, which is the health system itself, that we need to be sure we're accounting for, because it influences not only how practitioners provide care and how healthcare organizations deliver care, but it also influences how patients, potential patients, their family members might view the decision to access care. And this is, of course, really central to the kind of work that we're all doing. So I will stop sharing. I think I've managed to do that fairly well. Excellent. Okay. And obviously over to you, Sunita, and any questions from anyone.
Thank you so much. And I do have questions on that, but of course, I'll hold on that, and I'll invite the audience. Please put in your question, and I'm unsure if they can. Yes, you can raise hands and we can get you in. Abhijit, please.
Hi, Marisha. Thanks for kind of doing this, and kind of probably, and apologies for putting you on the spot by not having the other two panelists. But I guess, I mean, the advantage, I mean, we always see the kind of glass half full. The advantage of that is that we can now kind of discuss some of these in more detail. So my question to you is basically, what I'm hearing from what you said is that sometimes some of these decisions that are made are which we don't think about, are contingent on what is available and what is not available in terms of the health systems. Could you give us, to illustrate this a little bit better, could you give us some examples of what you came across, and whether and examples in both ways, in terms of things that eventually turned out to be ethical, and things which were maybe unethical or falling in the gray area because the decisions were made based on the reality of the health system?
Yeah, absolutely, absolutely. So thank you for that question, Abhi. So it's really important to acknowledge that ultimately the extent to which these decisions can ever really be ethical is right, totally constrained by what's available. So some things that people said, for example, in the specific context. So I spoke to practitioners and advocates who lived and worked kind of across various provinces of South Africa. And in some of the more rural contexts, practitioners were really clear that their patients would never be taken for referral by the local psychiatric hospital. And that influenced their decision, because in some cases they decide, okay, I feel competent. These are generalists. A lot of them are young doctors, community service medical officers who are basically just out of training. And some of them would decide, okay, I feel competent to provide care for this person, so I'm going to admit them into this hospital. And others would say exactly the opposite. I don't feel competent providing care for this person, so I'm not going to admit them, because I know they'll never be referred up to the psychiatric hospital. So you've got this kind of double tension where it starts to rely just on individual providers and their personal confidence, their personal experience. So that's one potential example that might kind of answer some of speak to some of the question that you were asking, Abi. I think another really important one that I briefly mentioned, but that really, I think, matters, and certainly matters for the broader research context when we start to look at how people are accessing hospital care, things like that. Because patients are being admitted to a general ward, different providers and advocates voiced their views about whether or not that was a good thing. So some people believed that was beyond a shred of a doubt the right thing to do, because it meant that people were closer into their local community, the kind of arguments we hear from global mental health. But what it also meant for others was, this is not a really specialized facility for people who are dealing with a mental health condition. General hospitals are set up for practitioners who, for patients who have a physical health condition. So, they're laying in beds all day, and they're not allowed to leave the ward. They're not allowed to go for walks. They're not allowed to, do these sorts of things. So practitioners and advocates alike kind of differed on their view as to whether that admission to a general hospital made for better decisions or indeed for worse. So yeah, I hope that answers your question. I know I can see all this stuff in the chat, so I want to save time for other
Okay, thank you, Marisha. That was a very detailed response, and that's the kind of advantage of having a little more time on our hands. So we have another question in the chat box, and I'm just going to read it for you. And I'm going to have, if there's no other question, I'll have my question to you. So the question that this is anonymous attendee, and the question is, what are some barriers to ethical practice in the health system, especially across countries? If you may have insights across the countries.
Yeah, absolutely. That's a great question. So I will obviously just first say the research that I did was specifically in South Africa. So I don't have a strong sense of sort of a comparative evaluation, but I think some potential lessons that one can draw from that case study that might apply elsewhere would be around, of course, not only how the health system is structured, but the inevitable and always point of how many resources are being poured into the system, of course, is going to constrain or shape what kinds of decisions can be made. I think in terms of the barriers to ethical practice, I think in some ways, that's quite a tough question, because, of course, in this particular case, some people would argue that any decision to admit involuntarily at all is unethical. So in that case, it's really just the law itself is the barrier to ethical practice, right? But if we were to expand a little bit, I think so much of what came out of the research that I was doing was to do with the fact that ultimately, when we think about clinical decision-making in general, we think about it as being this very discrete kind of task, right? We've got these specific considerations we weigh up, whether they're legal, whether they're, biomedical in some way. But what just became really obvious was that there's no way to make those decisions in isolation. So perhaps one of the key barriers that we see is that depending on how the health system is structured, depending on how we've decided to organize our delivery of mental health care, the extent to which those system considerations kind of influence or infiltrate that what we think of as a sort of pure ethical decision is going to vary. So I don't know exactly if I can answer the question of what are the barriers, but I think it's important as we move to improve systems, both through research and through our practice, to start thinking about the ways in which some of these systems-based considerations start to seep into the kinds of decisions that we make, and start to think about whether that's right or wrong. And to be honest, I don't I think it depends. I think it genuinely depends whether that system-based consideration makes for better or for worse ethical decision-making.
Okay, thank
I
you.
hope that answered the anonymous question. Please feel free to write back if not.
So I think there are going to be hands raised. I'm waiting for I'm not able to see them, but I'll sort of, there's some access issues that our reporters are taking care of. So in the meanwhile, I'll use my
sorry,
privilege.
Smita, there is Aruna who has been added here, who has a question. She has her hand raised.
Okay,
she
so
wanted to
can
ask
I
a
just
question by
complete
herself.
sure, I can do that. I'm just going to complete my question, and Marisha, you can take Aruna's question first, but I just wanted to put these things on the table. So one is, just because of my training in ethics, I just wanted to know if you had any kind of, in your study, I understand this is your doctoral work and super fantastic work, not surprised. So 2 bullet points here and kind of comment or question. So one is, in most of our LMIC settings, we don't really have warmed up with the idea of clinical ethics councils or clinical ethics committees in the hospital setting. And that applies to the range of healthcare services and the ethical decision making, all kinds of things, just not for this particular health needs. So that's one. And what have been, if you had sort of, incorporated anything around this in your work. So that's one. And how does that play out? And the second is a bit of a larger question, and something goes back to how the medical professionals are trained. So it is really about the medical schooling. And what's the kind of, one is, the whole legal strand, but it's the most important is what are our professional integrities within the clinical care settings. And it is very closely linked with what the medical schooling does to the students or the to-be doctors. And if the healthcare providers are willing to walk a extra mile, responding to the constraints of the healthcare systems and constraints of the legal system. So you can hold back on responses, and I would invite Aruna, please go ahead and ask your question. Aruna, please.
Yeah, thank you. Can you hear me?
Yes.
Okay, thank you so much. I really appreciate this talk because when it comes to mental health and global mental health, and I'm stepping into this field, being in other fields for a long time. So I find some of these discussions are kind of one-dimensional. So it's very important to talk about the role and the limitations of the healthcare system. But my question is really, the healthcare system in itself is not a monolith, right? Even if you're talking global north and south, even within a country, how healthcare plays out is very different. So I have an anxiety disorder, and when I was living in the US a few years ago, I took myself to the emergency room because I was having panic attacks. And, the doctor said, I recognized that I was having a panic attack because I'm equipped to do so. But then the doctor said, we are going to give you something to help with that. And he wrote me up a prescription for a benzodiazepam. And, at the time, he didn't say that this is what I'm giving you. These are the side effects. There wasn't a lot of detail provided, which in retrospect, perhaps the state of mind I was in, I couldn't have absorbed it. So it did serve the purpose at that time. So when we are talking about a health system where, you're supposed to respect privacy and be transparent, even within that, there's so much complexity. And then when I was back in India and I was consulting a neurologist for an anxiety-related physical symptom. And I remember when I was standing in line to collect my medicines, and I just weaned off my benzodiazepam. And there was someone standing in front of me who had a prescription for Ativan. And I was so tempted to tell her, oh, do you know that this medication needs to be taken with a lot of care? But then I thought, what is my business doing that, right? Because as much as I have had that lived experience, I probably can't overstep and take on this role of the custodian for the other person. And I don't know how the doctor has prescribed the treatment to them. So So I guess these two examples are just to, restate the question that even when you're talking in the context of a health system, there are so many complexities within it. So in terms of your research, how did you account for that or note that, and how did it impact the outcome, or did you note it and say it's something we need to keep in mind?
Yeah, thank you so much for that question. And thanks for also sharing your experience. I really appreciated hearing about that. You're absolutely right. A health system is, of course, not a monolith. And yeah, in a longer version of a talk, I probably should have acknowledged that a bit more clearly. But yeah, so when I spoke to folks, I spoke to a range of people who were working as mental health care practitioners. Many working in rural environments and many working in urban environments. And what's so interesting about the point that you raise is, yes, the health system is not a monolith. But what's really interesting is that some of the challenges that run through the health system are still fairly similar depending on kind of where you are. So for example, in South Africa, I heard from folks who were working rurally, as well as from folks who were working in urban settings, literally just a mile away from the psychiatric hospital, that it was functionally impossible to get their patients referred to the psychiatric hospital. So the ways that they went about managing that challenge were vastly different, because often, as you might imagine, in an urban setting, there were a few more resources available within the hospital, the general hospital itself, compared to the rural hospital, where that wasn't necessarily the case. But yes, it's really interesting to note how, even if the sort of overarching theme of the health system, which in this particular case was that psychiatric hospitals were sort of overrun and people weren't being moved kind of through the system as the law would suggest, or as our sort of idealized health system might promote, that depending on your setting, people were managing that problem in very different ways. So yeah, I think it's a really, really good point. These health systems are not a monolith, and obviously, in less resourced parts of a health system, you're going to find a very different way of practice than in more resourced parts of the health system. So thank you for kind of raising that. Yeah, there's of course kind of differences there. And in my specific project, yeah, I've spent a lot of time kind of, when I was analyzing data, I spent a lot of time trying to look for kind of comparisons between how people were talking about their practice when they were practicing in urban settings versus when they were practicing in more rural settings. So that's just kind of one key feature that was different. Another thing that was different was, depending on where you are, your general hospital is potentially a very small district hospital, or a huge, 500 plus bed teaching hospital, which obviously are going to have different ranges of expertise. And so that also played a role in how practitioners described their decision making. And from advocates' perspectives of, their own stories of admission and others' stories of admission, the same was true. Depending on kind of which hospital you were in, depending on which area of the country you lived in, you would have a different experience. So yeah, thank you so much, Arna. I hope that I answered your question as well. Like, please jump in if there's more, or if I missed something. Sunitha, do you want me to answer your questions as well? Or I don't
if you can, and we have, let's say it's 6:04, so we have another 3 minutes, and then we'll close this session, and I'll hand it over back to Urvita.
Great. Okay, so the first question that you asked, Sunitha, was on clinical ethics consults. And to be totally honest, I didn't bring any of that into my work. What's interesting about the way that South Africa's mental health law governs involuntary admissions decisions is there are a number of kind of checks that are written legally, that are sort of legal processes that are written in, including, mental health review boards and these kinds of oversight groups. Depending, again, per our previous discussion, depending on where you are in the country, it would seem that you have differential kind of functions on how well those mental health review boards work. But I personally didn't bring any kind of clinical ethics consult aspect to the work. My project was very, very exploratory, and very much so just trying to see how people talk about these decisions at all. So that's the first one. In terms of the second one, I mean, I totally agree. How medical professionals are trained has so much to do with kind of what what ends up happening, right, in practice. And I was really struck by the point that you made of, whether healthcare providers are kind of willing to walk that extra mile to respond to the constraints of the system. And I think that's absolutely true. On the one hand, I think it's unfair that we make medical practitioners respond, have to walk that extra mile. We should build a system that works for everyone on the one hand. But on the other hand, what was really interesting in my work was that you could kind of see the split between practitioners. So you had some practitioners who took a very clear view that the mental health care system was only responsible for a certain range of things, and quite narrowly defined, tended to be quite a biomedical definition. Well, if you're not actively experiencing psychosis, I'm not going to admit you. That kind of if you will, gatekeeping about what the purpose of the mental health care system was. Then you had other practitioners who took a completely different view and who were much more like, well, I know this guy, he comes in quite a lot. His mother had just died. I know he's street homeless and he's come in, he's not particularly well. He's not necessarily in need of mental health care per the kind of legal criteria of the Act. But I think, I don't want him sleeping on the street. And so you saw these practitioners start to kind of reason about what they believed the mental health care system should do. And I think that plays such a, it's kind of undiscussed, but it plays such a big role in how people go about kind of positioning, in practitioners, especially how they go about positioning their own role, and then how that influences the decisions that they make. And again, tying it back to this point of collaborative research and trying to figure out how to include everything, including the health system itself, recognizing ultimately that the health system is made up of people, and these individual people can play a sort of massive role in how healthcare is delivered and what we actually see happening on the ground. So I'll leave it there.
So that's excellent, and we're quite on dot, and I'm going to give it back to Urvita. So thank you so much, Marisha, for this excellent, and you were privileged today to have the entire panel time for yourself, and all the question answer was very interesting, and I want to kind of connect with you a little bit later. So Urvita, back to you. Thank you, Marisha, and Urvita, over to you. Thank you so much.
Thanks, Sunita. And Marisha, one more thanks from me as well for stepping into this role. And we absolutely enjoyed picking on your brains. So with that, we will close this session. We'll be back in 10 minutes. Our next session is a panel. And I'd like to reassure all of you that all our panelists are in the room already. So we'll see you in 10 minutes and look forward to you joining us. Right, so because the recording has stopped. Hi, Karen. Hi, Audrey. Am I audible? Can you see me? We could just do a quick test. Hi, good to see you.
So good to have everyone ahead of time.
Exactly, yeah. Audrey, to give you context, we just one of the panelists joined in for the previous session. So we are so glad to see that all of us are here.
Yeah, it sounds like she did an amazing job from what I heard. So
yeah, right. Karen, are you here?
Yeah, can you hear me okay?
Yes, I can hear you as well.
I'm just
Vijay,
sitting...
if I could just, sorry, Karen, go on.
No, I'm just trying to find a place to sit. There's bright sun shining. I'm sitting outside an office which has Wi-Fi, so
okay.
The office is locked, so I'm just trying to find a good sitting place, but otherwise all is well.
Okay, great. And if I could just check if Crick could be brought back to the room, please. So Audrey, Karen, we are going to start in around 9 minutes from now.
sounds good.
Hi, Rita. Can you hear me?
Yes. Hi, Crick.
Okay, great. I thought
Thanks for joining in.
No,
thanks for joining in early. We are just taking a small break. We should be back in 8 to 9 minutes.
Okay, great. Thank you.
Urvita, can I bother you for a second? I'm so sorry.
Sure, Marisha.
Should I leave and rejoin through the general webinar?
Yes, sure. Or
Does that
maybe
make
we
the
can,
most
if
sense?
you'd
So
like,
that
we can, I'll just check if we can make you an attendee. And
Oh,
feel free
yeah,
to come back if you have any questions.
Okay.
Vijay, could you check
Yeah,
if we can make?
and well, you know, she can even stay as a panelist. There's no harm, but I'll leave it.
Okay.
Yeah, there's not a problem.
Okay.
It's just that we are trying to kind of, you know, have a little more streamlined access stuff. So Marisha, very welcome to stay on, of course.
Okay. I just don't want to, I didn't know if I was going to stay pinned or something and for the next panel, and I didn't want to.
Yeah, I think that's removed now. Yeah.
Okay.
Yeah.
Oh, sorry, I accidentally muted myself. Thank you.
Hi, Rahul.
Am I audible?
Yes, you're very audible. Thanks for joining in, Rahul. Vijay, if I could request you to resume the recording. Thank you. So welcome back, everyone. Very pleased to introduce you to our next moderator for the session on Is Participatory Research in Mental Health Truly Participatory? So I would like to invite Rahul Shidai to chair this session. Rahul Shidai is an associate professor of psychiatry at Pravara Institute of Medical Sciences in Maharashtra. And he's a DBT Wellcome Trust India Alliance Fellow in Clinical and Public Health Research. Rahul, despite being unwell, I'd really like to thank you a lot from the bottom of our hearts, from the organizing team. Really appreciate that you have joined in and look forward to the panel discussion. Thank you.
Thank you. Thank you, Urvita. Thank you for inviting me. And it's a privilege to moderate this panel discussion. I hope I'm audible. There will be some
yes, very clear.
There will be some background disturbance at my end because there's a huge road kind of just across my house. So just excuse me for that, but I won't be speaking. So you will be spared of that. So thank you so much for that introduction. What we will do now is we have only like close to 42 minutes from now. And in interest of time, I'll very, very quickly introduce our panelists today. And then after that, we will have 3 sets of discussions. So in the first set, there will be a specific question for each of the panelists based on the kind of work they're involved in. And then there will be a common question for all of them, and they can express their thoughts and opinions around that. I would request all of you to kind of keep typing in your questions as and when they arise in your minds in the chat box. There are rapporteurs who will be collating those questions and will try to kind of address as many of them as possible. Given that we have very little time today, it will probably not possible to address all the questions, but let's see how it goes. We have started well on time. And as I said, I'll very quickly introduce all the 3 speakers in the alphabetical order. So I'll first introduce Audrey Prost, then Krik Lund, and finally Karen Matthias. So I'll first introduce them. And my introduction will be very, very brief because most of them are anyway very famous in the field of global health. You can simply internet search them and you will kind of, they have written hundreds of papers actually. So none of them requires any introduction, but I'll be very brief. That's the reason I'll be very brief so that we can have more time for discussion. So Audrey Prost is a social anthropologist and epidemiologist and professor of global health at University College London. And her area of work is development and evaluation of participatory community interventions. She is associated with, she has been one of the leading collaborators in the Ekjut trials, which have been running for last several years. Krik Lund is co-director of the Center for Global Mental Health, King's College London. He's a clinical psychologist. He's a clinical psychologist by training and has conducted research on mental health policy in low and middle income countries. And Karen Matthias is a public health physician and a researcher with a focus on participation, equity, and mental health in communities. She has worked in India for most of the last 20 years and is a founder of a very interesting initiative, which is named after a flower, interestingly, Burans. And this is based in Uttarakhand, North India. And she is a senior lecturer at the University of Canterbury, New Zealand. I had specifically requested all of them to kind of send their 2-sentence introductions, and you can see how modest they are in terms of introducing themselves. The rest of that you can actually search on the internet, and I'm sure they will be speaking about their work through the set of questions which we will be doing now in next 40 minutes or so. So let me then now start with my first question to Krik. So Krik, you are co-director of Center for Global Mental Health along with Dr. Charlotte Hanlon. So you are basically one of the leading figures in the field of global mental health. Why do you think this particular discussion on participatory research is needed? And we are all looking forward in the broader perspective of global mental health. So from that perspective, if you could throw light on this particular issue. And I would request all the speakers to limit themselves to around 2 to 3 minutes so that we can cover many topics as possible. So over to you, Craig.
Okay, thanks very much, Rahul. Can you hear me first of all? Okay, good. Well, thank you for your kind introduction. It's really great to be on this panel together with Audrey and Karen, and really wonderful to be part of the broader discussion in this conference. So I think it's really vital that we have this discussion about inclusion in global mental health research for a few different reasons. The first and perhaps most obvious is that people with lived experience of mental health conditions are often already marginalized and disempowered. So if we try to conduct research or deliver interventions without their meaningful participation, we essentially risk marginalizing and disempowering them further. In other words, we may have very noble intentions to try and conduct research in this area, to deliver interventions to narrow the treatment gap or to reduce the global burden of mental health conditions. But in some ways, if we don't include people with lived experience and a range of other stakeholders, we actually maintain some of the inequities which are already present. And my second point is that historically, research in mental health has been conducted on or about people with mental health conditions with very little consideration of their own experience and how they might be experts on their own needs and preferences. And this covers a range of life areas, including decisions around their treatment, their livelihoods, identity, meaningful participation in community life, and so on. And this is my third point, as the field of global mental health really grows and matures and indeed diversifies, I think it's vital that this field and the research agendas around it are shaped in a meaningful way by people with lived experience of mental health conditions. I think this is starting to happen more and more, but I think we still have a long way to go. I think it's very exciting, but I think it's really important that we do this in a meaningful way to make sure that it isn't tokenistic. And I can give some examples perhaps later in the panel around how this could be done. And the final point I wanted to make, just by way of introduction, Rahul, is that I think it's really important when we consider participation in global mental health research that we think in a very broad way. There are so many diverse stakeholders who are involved in mental health. In the words of one of my colleagues, mental health is everybody's business. So policymakers, service providers, users, people with lived experience, families, caregivers are all really important and all really need to be included. So when we're thinking about particular research projects or developing research proposals, we need to think carefully about who could participate with researchers in the overall research process. So I hope that answers the question, at least initially, some initial ideas. Thanks, Rahul.
Yes, thanks, Craig. And I think it's important to get, for all of us to get that perspective from a global mental health perspective, as the field is moving forward, how people like you who are the leaders in the field are looking at this. I'll now move on to Karen, and she has been working directly on ground in Uttarakhand, a state in the north of India, with people who have lived experience and who have multiple disabilities. So, Karen, Craig has alluded to multiple reasons why global mental health is important from a global mental health perspective. But what is your take on this, more from the ground level? Because you are connected to people. I mean, you have been doing this work for quite some time, and despite being someone who is not from this country, you know the language very well. You get connected with people so very well. So we are very interested to know your perspective more from the other side. Other side, as in you are very much a researcher, but someone who is doing really a ground level.
Thank you very much, Rahul, and thanks for setting the scene in such a great way, Crick. I think when I am reflecting on why participatory research is important, I think that one of the most important things that it contributes for me is that it ensures that the research is really grounded in a local context and it meets the needs of local people. I think that for when global mental health started as a kind of movement earlier in the century, there was quite a kind of one size fits all kind of idea. And we've, there's been a huge growing recognition that each local context has its own local needs and local assets, and it's really important to engage with those. I think it's just in terms of justice, I think it's really important because it's a fair way that, nothing about us without us, which Crick has also mentioned, it means that it's a less hierarchical approach, and we know that delivers things that are more meaningful for local people. I think that participatory research also recognizes that expertise is not only about academic or professional training, and there's expertise that people have in that. There's also some really good evidence that when you use participatory approaches, the outputs and programs are more relevant and more acceptable to local people and to people with lived experience, and actually lead to improved outcomes. So for me, there's just, there's not many reasons not to do participatory research. Thanks.
Thank you, Karen, and thanks for bringing that whole aspect of justice as well as the needs the felt needs of individuals and where the expertise lies, because most of the times, somehow we are groomed or trained in a way to kind of to see that those with degrees have expertise, but probably that's not really the case. So we will now move on to our third panelist, Audrey. So now, Audrey, I would just like to play devil's advocate with you over here, because you are very actively into the participatory research. So the question which I'm posing to you is, what if we continue doing the same things which we kept doing earlier? So what if we just go ahead with our conventional ways of doing this?
Oh, thank you, Rahul, for this challenging question. And I'm feeling optimistic, building on what Cricket and Karen were just sharing. I think there's increasing recognition that people with lived experience and other significant others need to be involved in the development of mental health interventions. And we see this very much reflected in the work of several civil society organizations in India, Sangat, Banyan, Ekjut, Burans, and many others around the world doing work that involves participatory methods. What seems to me very important, though, at this point is to think critically about what we mean by participation. Co-design and co-production are two terms that are very widely used now, but can actually encapsulate a very wide range of approaches to participation. On the one hand, co-design can mean engaging experts by experience and others through a very short phase of, say, focus group discussions or workshops to tweak interventions that have been developed elsewhere and give them some local flavor and make them more locally acceptable. That's one approach. On the one hand, co-design and co-production can also mean trying to develop long-term, more equitable partnerships with groups of willing experts by experience and having some critical reflections about processes and about power, giving those experts by experience the space, the power to question both the need for intervention, but also the components of the interventions that are being proposed. My colleagues at Ekjut, led by Dr. Sachin Barbde and Sumitra Gagrai, are leading a community-based rehabilitation program for people with psychosocial disabilities in Jharkhand. And they've developed this very much with experts by experience. And the program continues to be refined iteratively through their inputs. There wasn't a sort of phase of intervention development that stopped and then a rollout. There's a sort of ongoing critical dialogue between the service providers and experts by experience and others. So in short, what I think we need to do is to push the existing good work further and expand our use of long-term deeper, more critical participatory approaches rather than relying on short-term, adaptive, qualitative research.
Thank you, Audrey, and thank you all the panelists for really setting this up very well. Being a moderator, I should not be speaking much. I should only be moderating, but I cannot prevent myself from just sharing one very quick anecdote which Dr. Abhay Bang usually shares during his presentation. Some of you may be aware of Dr. Abhay Bang's work in Gadchiroli in India, and in 90s, in early 90s, late 80s, when they first started their work, they did a prevalence of sickle cell anemia, hemoglobinopathies in that particular area. And then they shared the findings with the community members. And the community members actually got back to them and and told them that, sir, thank you so much for all that excellent research, but that is the problem in your head. That is not something which we are really at least worried about at this point of time. Our problems are slightly different, not slightly, they are way too different. We are more worried about our newborns dying. And that's how we shifted on to, that's what I've heard from him in some of his presentations. And that was a great lesson, because without even talking to people, what we will end up doing is basically projecting our own ideas on what people out there feel like and think like. So okay, so because we are doing good on time, we will move on to the next section now. And now this particular section, in this particular section, I'll pose a similar question to all three panelists. So the question is, and it's not really a question. Basically, we would like to know how each one of you have used participatory methods, research methods in your work, and were you able to meaningfully engage those with lived experience or those who really mattered into your research, and what challenges you faced. So I'll first request Karen, then Audrey and Craig to share their kind of real life experiences in terms of using these methods. They have also shared links of their work, and I'll simultaneously I will copy paste them in the chat box. Those who are interested can know more about their work through the research links which they have shared. So over to you, Karen.
Thanks again. Yeah, I thought I would share briefly about the first participatory co-production project that we worked on with Sumit Jain and the University of Edinburgh and others. And we were looking at how to develop a contextualized recovery tool, particularly for low-income urban communities in North India. And so we're recognizing that many of the existing tools are made for Western or Euro-American settings, and there's a very different context in busties or low-income settings in India. So we had an expert by experience group that we formed, and we met frequently with workshops and used a lot of participatory rural appraisal approaches, which I really recommend. Robert Chambers and others have really pioneered these, and they're really great for working with people who have a range of literacy or education. And we worked together, and I think it was a really, generally a really positive process. But I just wanted to share two examples that were quite challenging. Most of the people in that group, there was a mix of caregivers and people with their own experience of mental health problems, and most of them had very low literacy. And so we were talking about quite abstract concepts, and it was quite challenging for that group to participate. And so we really needed to move to much more like, let's go outside and find something that represents how you would like to participate in society. And one woman came in with a bicycle wheel that she had found lying, and she said, all the spokes are equal length, and that's how I want our society will, have a spin equally. And I just found that bicycle wheel such a great symbol of, equal equal power relations and participation, and in lots of ways that worked much better than whatever words we could have come up with. One of the other challenges I'll just share briefly was that we'd been trying to tell the group they're experts by experience, and they're saying, no, we're not experts. All we know is how to fill up our bottles at the water tap and get through each day. And then we had some pictures drawn to try and represent some of the domains of recovery that we discussed. And once they saw the pictures, which were drawn by a middle-class young person who was Hindu, and they were like, this girl knows nothing. You see, the father walking to school should be carrying the child's bag. Everyone knows that. And the man washing his hands before he goes to do his prayers, the tap should be here. And once they could see the pictures, we could say, look, this is all your expertise. And so that was, for us, were two ways that were really great to recognize the value of using pictures and of using symbols to optimize participation. I won't speak anymore. There's so many more things that we did quite poorly, and they're both written in the publications because we did lots of learning on the way. I wouldn't say it was a model process. Thanks.
Thanks, Karen. And I think what is important is kind of spending time with people. And many a times as researchers, we are so busy compiling data, synthesizing it, and converting it into publication that many a times we don't even have that time to actually interact with people and I mean that spokes the picture of the image of a spoke and having equity or equality through that is something fantastic. So over to you, Audrey, now. And by the way, I have shared the links of Karen's paper in the chat box. Please copy paste that, because once this particular thing gets over, you won't have the chance to do it. I mean, of course, you can find it on internet, but as it is live, please copy paste it so that you can refer to it later. Over to you, Audrey.
Thank you, Rahul. And I like Karen's learning along the way. I think it really encapsulates what a lot of participatory research is about. In ECJT and with other partners, we've used participatory learning in action, which is related to participatory action research and the family of approaches developed by Robert Chambers and colleagues. And we've done participatory learning in action in a form of a cycle of meetings with community groups, sometimes women's groups, sometimes adolescent groups, or people experiencing mental health conditions. In these groups, members identify the main problems that they face, and they prioritize themselves a small number that they would like to take action on. They analyze the causes of these problems, often using pictorial or storytelling methods, where again, we're able to engage with people with low literacy. And then they define and implement strategies to address these problems, and they have to think critically about the strategies that are feasible to implement within a local context, with the resources and the links and the assets that the group has access to. And so this kind of participatory process is very widely used, of course, in other areas of health and development. But we found it very helpful to understand and to address a range of problems related to women and children's health, including adolescent mental health. But we found that when you're trying to meaningfully engage people with lived experience, just getting a group together isn't enough. And you need to think about equity in all dimensions of these types of interventions. So the facilitator needing to be from the same community or have lived experience themselves, allowing experts by experience to decide the place, time, and the pace of discussions so that they feel safe and respected within these fora. These sound very obvious, but they can make a world of difference. The one challenge I wanted to talk about was the challenge of scaling up. So participatory interventions are often very powerful and very beautiful when they're in the hands of very committed experts based in civil society organizations that have a strong participatory ethos themselves. But it's quite difficult to scale them up within systems, institutions and governments that typically employ more top-down models of decision-making. And what can happen is there can be slippage and a tendency to then start to prescribe problems for the group and to start prescribe the solutions that they might prioritize to try to fit within a certain governmental or organizational agenda. And that's quite a difficult political thing to get to grips with. And at EGJUD, we've been fortunate to be able to scale up participatory interventions at the level of a state in Jharkhand. And I'll put a link to this in the chat. But one of the things that we found helpful is Carl Taylor's seed scale model, which argues that you basically need tripartite alliances between civil society organizations, governments, and communities to try to achieve any lasting change. And that model also has a number of principles that you need to base actions on previous successes and local assets. You need that three-way partnerships, and you need local data and local planning. So I think thinking early about mechanisms through which you can scale up participatory approaches so that it's not just, a single study or a lovely randomized controlled trial somewhere, but you think about how to institutionalize the participatory ethos at different levels. It's useful to do that early.
Thanks, Audrey. And I assume that you will post the link of this particular work in the chat box. And one of the participants is also asked to type the name of the model. But one particular thing from my end, Audrey, I remember last year your group had published a systematic review on the kind of challenges one can face in community-based interventions for nutrition interventions. And there were kind of great learnings as far as I remember. So if you could also, if it is relevant and if you could post that, it will be, but I'm not sure, but I thought that it was something which did kind of throw light on the challenges in terms, as you very rightly mentioned, it is not just enough to bring people together. You have, it is just the first step, although a very important one. But then there are many things which follow. So just as a housekeeping thing, I'm sure this recording will be available. So Sangat staff who is organizing the event, they will make this recording available. So I don't think participants have to worry about this. But if there's anything else, do let me know and I can share that. So now over to you, Craig. And as you speak, I'll share the link of your work in the chat box. So over to you, Craig.
Okay, great. Thanks very much, Rahul. And thanks, Audrey and Karen. Really, really interesting to hear more about what you've been doing. And I think like you, and perhaps more so, I'm really learning as I go with this and there's lots of mistakes along the way. So I just want to share an example of work that we're currently involved in. This is the ALIVE project. ALIVE stands for Improving Adolescent Mental Health by Reducing the Impact of Poverty. It's a Wellcome Trust funded collaborative award, and we're working in circumstances of urban poverty in Colombia, South Africa, and in Nepal. So it's Bogota in Colombia, Cape Town, where I'm based in South Africa, and Kathmandu in Nepal. And essentially, we try to design a prevention intervention which addresses the way in which poverty increases risk for depression and anxiety among adolescents. And so that includes two components. The one is a poverty reduction component through cash transfers and financial literacy and improving bargaining skills and savings in households and among the adolescents themselves. And then secondly, an intervention to try and strengthen self-regulation, by which we understand the capacity to set goals and to maintain goal-directed behavior despite emotionally salient and really challenging settings. So what we've been trying to do through this whole process is to involve adolescents in the entire research design process, the intervention, development and design. And then we will be running a pilot randomized controlled trial, again, which we're hoping to involve adolescents in. And the way we're doing this is, and Mark Jordans is really leading on this aspect in the project, is that we've established adolescent advisory groups, one in each country. And the groups meet roughly every 2 months. They vary in size from about 8 to about 20, 25 adolescents. And we've started off the process by engaging with them around the ground rules of what they would hope to achieve from this, what they would get out of participating in the project, and how they would like to run these advisory groups. And then we've gone through all the different stages. We're in the first year of a 5-year program, so it's really very early days. But at the moment, we've been doing a lot of exploratory work, trying to hear from them about their experience of living in socioeconomic adversity and how they understand that, how they understand it might affect their own mental health and well-being. And then also getting their input on the formative qualitative research that we're doing in each of the country sites. So going through the interview schedule with them, asking them how they would interpret and how they think other adolescents might interpret the particular questions we're posing, how we might interpret responses to those questions, and so on. And then in the next phase, we will be going through the instruments that we're going through a process of adapting and culturally validating at each of the country sites. And again, getting their involvement and their input on the design process. And then subsequently, when we work on the intervention design, we will hopefully have the adolescents very involved in that. And I must say, it's the first time for me that I've been involved in this quite direct participatory kind of way, and it's been incredibly energizing and empowering, I think, for the research team at least, just to hear and be able to engage directly. Just a wonderful group of incredibly insightful adolescents. We haven't specifically tried to delineate those within the group who have lived experience of depression or anxiety from those who haven't. And I think this is an interesting discussion. Maybe I'd be interested to hear others' views on this, but sometimes that kind of labeling can be stigmatizing or excluding in itself. Often it's more interesting and I think more valuable just to hear about people's own experience. And I think my own reason as well is that we all exist somewhere on a continuum from severe disability to mental wellness, and we even move up and down that continuum during the course of our lives. And so we really are all in the process of trying to understand more about our own mental health and how we can strengthen and support each other. So I'd be interested to hear others' thoughts on that. But that's really, in a way, the final thing I just wanted to mention is that we are also trying to research the process of engaging with adolescents in this way in itself. So we've developed an ethics protocol, again, with input from the adolescents around the participatory process itself. And then we'll be feeding back the results of that to the adolescent groups. So again, we're learning as we go. It's not a straightforward process at all, as others have mentioned, but I hope that gives you some idea of how we're trying to approach this. Thanks, Rahul.
Thank you. And thank you to all the panelists for sharing the excellent work which they have been involved in. And you've got all the links in the chat box. Do copy paste them in your Word file so that you don't miss them. And even if you miss them, you can do an internet search. And I would just like to emphasize that this is just the part of the work which all of them have been involved in. There are at least 10 different things all three panelists are part of, which are in a way, one way or the other, participatory in nature. Just to give an example, Crick was the CEO or for the lack of better term, director of a huge research program consortium called PRIME for 8 years. And it was not just participatory from the participants' point of view, but from the researchers' point of view as well. So just an example, and he has not talked about PRIME at all. He has not even uttered that word. But then there are so many other things which Audrey has been involved, Karen has been involved, and if you are interested, you can write to them on their official email IDs, or you can do an internet search. We have 12 minutes from now, and Crick has posed one question, and he would like to have inputs from other panelists. And additionally, I have one common question for all the panelists, which is basically, I mean, it's like your wrap up in terms of what do you think should be the way forward for global health research in general and global mental health research community to make research truly participatory and not just as some kind of a lip service. So we will follow the order of first Audrey, then Craig and Karen. So Audrey, over to you. And given the fact that we have like 11 minutes from now, if you could restrict yourself to around a minute or so, we can take 2 or 3 questions which have been there in the chat. So Audrey.
Thanks very much, Rahul. I think for me, a priority is to disseminate methods and models of co-production and engagement that go beyond adapting existing treatment packages through short-term qualitative work, focus group discussions, and a small number of workshops, and instead showcasing models that rely on longer-term dialogue between civil society organizations, experts by experience, service providers, researchers. And we may find that just as Abibang shifted research priorities in response to what people were telling him, this also leads us towards more work on addressing the social determinants of mental health, the kind of work that Crick was describing just now, and really trying to build mental capital rather than, again, simply adapting existing treatment packages. And that sort of wider work on the social determinants of mental health may in fact be where the greatest public health gains lie ahead. So I'll stop here given the time we have.
Thank you, and over to you, Craig.
Yeah, thanks, Rahul. I mean, I really agree with what Audrey was saying about long-term processes. I think, meaningful participation is about building long-term partnerships rather than one-off events. And so as researchers, I think it's really important that we establish those partnerships and we agree on terms of reference early on that are beneficial to everybody involved, and spend a lot of time listening to what are the needs of local communities and the places where we are hoping to deliver the interventions, the people who we are hoping would benefit from those interventions. And so I think this involves including people with lived experience very early in the research process. This includes, for example, in the development of research grants, and establishing institutional partnerships. It's challenging because sometimes in those early stages, you don't yet have the funds to pay for salaries, to pay for time. And so I think one needs to think quite carefully and creatively around how you could compensate people for their contribution to the development of research grants, which may or may not be successful. So I think that's something that needs further thought and planning. And again, if you have long-standing partnerships, those can be carried over from one grant to the next, and can really help you to build those partnerships. I also think it's really important to build the institutional capacity of organizations that are led by people with lived experience, and to support them in a as far as possible in an equitable way. I think it's really interesting. One of PhDs that I supervised by Sharon Kleinke, she went through a really rigorous process of mapping out user-led organizations working in mental health in sub-Saharan Africa. And one of the key themes was the struggle they faced with just building their organizations and the multiple hurdles and barriers that they faced. So that kind of institutional capacity, I think, needs a lot of work. And then the final point, I think, relates to a point I made earlier, is that we really all need to listen to our own mental health needs. We're all on a journey here. And so it's not a case of distinguishing as sort of us and them, but thinking together about how we can support each other to strengthen our own mental health and strengthen others' mental health. That's all from me for now. Thanks, Rahul.
Thank you, Craig. Over to you, Karen.
Thanks again. Completely support what both Audrey and Crick have shared. And I think three things that I think are important. One is that we all need to keep building our skills in working in a participatory way, and particularly to work in a humble way. I think it's very easy to for people who've had a more opportunity for education to just easily jump into leadership, and I know that I've made that mistake myself often. And so working with others who've also done more work on participation has been really helpful for me to keep doing that critical reflexive thinking of how are we doing this, and is it genuinely listening instead of ticking boxes. Following up on what Crick said about the way that we do funding, I really think we need to normalize participatory approaches, but it is quite challenging. And we had a couple of years ago working with a really wonderful adolescent advisory group for a Grand Challenges call for proposals. We developed a proposed proposal, which required participation from community members. It was called Gup Shopping Games. We had a bunch of very, very energetic young people, and we weren't successful in the funding. And they were really, really upset. And I felt ethically that we weren't in a strong position because we had engaged them, they had contributed with all their hearts, and we didn't have any funding to implement things. And so I think we also need to critically reflect on the way that we make participatory funding calls, which we, I think is a good idea, but how do we do that in ways that respect the contribution of all those who are involved? And it just sometimes is quite hard to manage that. And I think we need to do more thinking about how participation is ethically respecting the time and energy of people who sometimes in very disadvantaged settings. So that's my thought, is we've still got lots of thinking to do to do this well. Thanks.
Well, thanks, Karen. My 2 cents, and I'm saying this only because Audrey asked me to kind of even say a few things or what I feel. What I feel is that many a times we involve community members, and then we kind of do things with them. And once our project ends, or once that grant writing cycle ends, we have to move on to something else. And that is kind of a very, very big, people on ground are not seeing this as grant cycles or project cycles or research cycles. For them, that's a serious business. And of course, it is serious for us as well. But we will have to think of mechanisms in which we have some kind of a permanent work on ground, and we overlay our research on that if it is feasible and possible. Otherwise, it's a very, very big disappointment for people who have got involved, and we need to be careful of that. We have 4 more minutes to go. And there is one question which is interesting, and there are 2 sort of comments. I'll just pose this question to all the panel members. And there was one hand which was raised, Vidula. So if you have a question, do let me know in the chat box. In the meantime, I'll quickly have this question, and this is open for all the panelists. So this question is, how do you navigate the decision-making of a person with lived experience in seeking care, in participating in research, etc., when it goes against your responsibility as a clinician or researcher? So you have a responsibility as a clinician or a researcher in a particular way, but then at the same time, you also have to navigate the decision-making of the person with lived experience. So what do you think is the best way to kind of deal with that? So it's open. I think all panelists can have their views on this particular question, because this captures the essence of what we have been discussing till now. And then probably we will end. So maybe we will start with Craig first, then Audrey, and finally Karen. Craig?
Okay, sure. I saw Karen had her hand up, but I was interested to hear what she thought.
Okay,
let me share I can give my thoughts. I think it's really important that when we design studies, we think carefully in the design of our ethics protocols around how we would manage scenarios like that. So we build in place, what are the limits of the responsibility of the research team, and where those limits run out or you run over that boundary, who would then take responsibility for providing care or support in that particular setting. And often what we're encouraged to do by ethics review panels is to really think that through very logically. So what is the referral pathway right until the point at which the person gets the help and support that they need? And that may involve a range of different stakeholders in the local community setting. I think it also depends a lot on what the particular conditions are, what the particular circumstances are, and also what the resource constraints are in those settings as well. Often we work in very, very constrained environments. And so one needs to think carefully about what one could mobilize within those settings. Yeah.
Karen, I would request you to respond to you in the end, because this particular question is asked by someone who had experience working in Buran's project, interestingly. So maybe Audrey, your views on, and I'll repeat the question. As a clinician researcher, you have a certain responsibility, but at the same time, how do you ensure the overall decision-making process of participation in research studies and the whole process?
Thank you, Rahul. Oh, sorry, Karen,
sorry.
you wanted to go on? Go on.
Sorry, I think now you go ahead, Audrey. I was getting confused.
I think you'll have a lot more to say about this, perhaps from a clinical perspective, Karen. I have mostly been thinking about this as someone doing trials of public health interventions at a community level, rather than thinking about individuals, because in terms of individuals, as Crick said, we have to have lots of governance processes in place and to think about that quite carefully through ethics. The bits that I have found most challenging, and I've learned a lot from discussions with Egdred about this, is thinking about our obligations to, for example, control areas, control villages, people who are left out in the pilot trial or in the full trial. And what if the intervention doesn't work? They never get anything, although they have expressed an interest in doing some work to improve mental health in their communities. What should be done? What is the responsibility of the civil society organization that supports this and that bears the burden of being there and having to respond to queries, as opposed to a researcher who may be able to extract themselves somehow? And what is the responsibility of the funder? And I think it would be good to have a critical discussion with funders about benefits to control areas. And many of you are ethicists, so you will think about this quite often. Is there a system in which, you know, we basically force people to think about benefits to control areas when there are huge unmet needs in mental health? We really think about this very consistently, and we put funding towards ensuring basic minimal provision of services and beneficial interventions in control areas.
Thanks, Audrey. And Karen, I would just request you to keep it very short because we have run out of our time. So over to you.
Yeah, I just thought I'd mention briefly, in a setting where there is very sort of limited access to mental health care, we have found that groups of experts by experience have ended up forming a psychosocial support for each other. And so this has happened in nearly every group we've formed, where they actually have a strong level of interaction, and they've said, we don't want to just talk about your program things that you want us to talk about. We actually just really like meeting, and we feel support from each other. And so a number of the groups, we've ended up sort of trying to meet some of the mental health care needs by saying, okay, one meeting will be more of a interactive psychosocial support, and the next one will be seeking your support as people with lived experience. So that's one approach that we've done. And yeah, would love to talk about it more, but our time is up. So thank you so much for the chance to join this panel.
Thank you so much. And it is very difficult to kind of wrap up everything because we have run out of time. There was definitely one question from Vidula Purohit to all the panelists. What are your experiences of sensitizing and building capacities of research teams on ethical issues of participatory research? But if she is very interested, she can write to all of you and you can respond her on email. I'll not kind of have it now. I would like to thank all the panelists, all the participants for excellent involvement and for really making this discussion very, very interesting. Really sorry for the time crunch, but because there was so much to talk about, and this is so close to our heart for all of our researchers, that we had to kind of do it the way we did it. So thank you so much, and over to you.
Thanks, Rahul. And thank you very much, Audrey, Karen, and Craig. It's always a pleasure to listen to all of you. And I agree with Rahul, there's never enough time to discuss this. So with that, there's actually no break now. We'll just proceed to the next panel. I would like to invite Sunita Kurpar for the who's going to be the moderator for this panel. While the panelists join us, I'd like to introduce Sunita Kurpar. The session that she's going to be moderating is called Research Consent in Vulnerable Populations with Compromised Capacity. To briefly introduce Sunita, Sunita is currently the professor of Department of Psychiatry and the professor and head of the Department of Medical Ethics at St. John's Medical College. She's actively involved in clinical work, in teaching, and in research. And as the co-chairperson of the Task Force for Boundary Guidelines of the Indian Psychiatric Society, She led the drafting of guidelines for doctors on sexual as well as non-sexual boundaries in the doctor-patient relationship in India. So I welcome Sunita, who will then go on to introducing the panelists.
Thank you, Urvita, for that. So before I start, thank you very much to the organizers for giving me this opportunity to moderate the next session. And we have an exciting topic and very experienced and enthusiastic panelists. So it's my pleasure to introduce them. Chetna Dugal is an associate professor in the School of Human Ecology in Tata Institute of Social Sciences, Mumbai. She has completed her PhD from TIS Mumbai and her MPhil from Clinical Psychology, NIMHANS, Bangalore. She is a psychotherapist with over 17 years of experience and has worked with children, adolescents, couples, and families. She teaches courses on psychotherapy and qualitative research and supervises trainee counselors and practitioners. She heads 2 field action outreach projects, the School Initiative for Mental Health Advocacy, SIMHA, an initiative that endeavors to promote well-being of young people in schools and other institutes through advocacy, research, and capacity building, and RABAR, an initiative to promote training, supervision, and professional development for mental health practitioners in India. She has co-authored a book titled Reflective Practice and Professional Development in Psychotherapy, which was released in February this year. Her research interests include psychotherapy, process and supervision, school mental health, child and adolescent mental health, resilience in communities, and religion and spirituality. So welcome, Chetna. Our next panelist is Hannah Negusi-Abnett, who's currently working as a trial coordinator for a project called SPARK. Hannah studied social pharmacy and pharmacoepidemiology for her master's degree. She has over 8 years of experience in research projects, working as a trial coordinator and a research coordinator. She was the trial coordinator for a trial which involved people who had severe mental disorders. The trial included participants with severe mental disorder who lacked decisional capacity to consent to participate in the study. Hannah is interested in clinical research, mental health, and women's health, and she's joining us from Ethiopia today. Welcome, Hannah. The last panelist is Anant Ban, who is a physician with a master's degree in bioethics from the University of Toronto. He is a researcher in global health, bioethics, mental health, and health policy. He is also adjunct professor at Yenagoya University, Mangalore. Anant was a past president, International Association of Bioethics, and his work is focused on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community engagement, and ethics of innovative technologies and ethics trainings for professionals. He is based in Bhopal. In his work with Sangat, Sangat colleagues in Madhya Pradesh, Anant has been involved in exploring pathways to integrate mental health into primary health care. This has involved working with health systems at the state as well as national level through task sharing approaches, which involves frontline health workers such as ASHA. Welcome, Anant. Okay. So just a brief announcement as to the format of today's session, because I'm very cognizant of the time. So we have one question for each of the panelists, and they could answer that in about 3 to 5 minutes. And then I will ask the other panelists if they want to add any of their comments. So we will, there's a question for each of the panelists. Then we will open it for questions from the audience. And then at the end, we will have a minute or two per panelist for their closing remarks. So we will start with Hannah. Anna, are you able to hear me?
Yes,
Yeah.
I'm really
Okay.
sorry, my internet
Okay.
connection is not that good, so I'll keep my video off.
Okay, that's fine. So the question to you, Hannah, there are 2 questions. Why is it important to include participants with compromised capacity into research studies? And how can one do this safely, and what are the limitations? Over to you, Hannah.
So I believe that people with compromised capacity and who lack decisional capacity should be included in research studies, of course, where the risk is low, because one, there is this principle of equity. People with compromised capacity should also get the chance to participate in such research, so they can benefit as well as the others. The other thing is, I mean, in research, we are usually testing new interventions or trying to see if something works better than the other. So in the long run, if these studies are successful, if the outcomes are good, they would be applied on people who lack capacity. So it should be tested on them as well, so that we can know it works for them as well. That's one.
The other part was, how can one do this safely when patients have compromised capacity? Hannah, we've lost you.
Sorry, I'm back. Were you able to hear what I said?
Not in the last 1 minute. The second part of the question as to how can one do this safely and what are the limitations?
Yeah, I mean, we have to put these safeguards. We have to use approaches, and we should use procedures to safeguard such participants. For one, I mean, in the study I was involved, we included participants who did not have decisional capacity, people who had severe mental disorders who did not have decisional capacity. So in order to include them, one, we had to assess their capacity with mental health professionals who had the expertise to assess capacity. Of course, there is limitations with the quality of the assessment, since we had to use psychiatric nurses for feasibility purposes. So that might have limited the quality of the assessment, but we still had to use professionals. And then we had to make sure that when the participants who lack capacity are not willingly who are not showing unwillingness to participate in the study, we had to seek informed consent from a guardian. So we did that. We had to make sure we sought consent from the caregivers.
We've lost you again. Hannah, you had spoken about involving the guardians. Hannah, we've lost you. Mahindra, will you be able to check with her? I will move on then to the other panelists for their comment. So, we got her back. Hannah, you're back?
Yes, sorry. So
yes.
To keep it short, so we have to have these safeguards for such participants and make sure that the benefit outweighs the risks, and to make sure that eventually involving them in such research projects will not have a negative effect on them, like having having safety reports for them, like entering proxy outcomes can be assessed for such studies. And I think we can have approaches to safeguard participants for such population.
That's great, Hannah. Thank you. Yeah. That's great. I think you covered the points as to why it would be important to involve them, as well as the practical limitations one can face and how you set about safeguarding. So can I ask Chetna, is there anything you would like to add to this particular question in terms of why include them and what are the limitations and the safeguards?
Thank you, Professor Sunita. And it's really nice to be here in the panel and be part of this discussion. I think Hannah has already shared some very important aspects that, the idea of inclusion and equity is really at the heart and center of including participants who are, coming in from marginalized groups and who might have compromised capacities. I think what I want to highlight in addition is the fact that there's always this balance between inclusion and protection that we are constantly trying to keep going. That's one aspect. The other thing that I was also thinking about as Hannah was sharing was that when we're looking at participation of people in research with compromised capacities, there's always that danger of homogenizing the group. And for us, particularly in a context like ours, where multiple identities, social identities intersect, we might need to even consider what we might need to do in terms of taking extra steps to ensure participation. So how do we actually realize this principle of inclusion? And I do agree with Hannah that having both ethical guidelines and safeguarding protocols in place can be important in ensuring safety of participants. And therefore, I think that this thing of ensuring that consent is ongoing and it's not just a one-time thing, but something that we sort of keep going through the process of research could be important. And also perhaps recognizing that vulnerabilities are also multi-layered. And maybe we can come back to this point at another time, but these were just a few quick thoughts.
Thank you, Chetna, for putting that together so well. Anand, can we have your points?
Sure, thanks. Pleasure to be on the panel. So, one thing which has happened in both medicine, the health space, and also research is this movement away from a paternalistic approach to a more collaborative approach. And if we really take that at heart, one has to recognize that the traditional lenses we have had, even in research, which have been lenses of exclusion in the name of vulnerability, is something that we need to relook. And sometimes the solutions might be a little bit simple as well. When we were discussing at the time of the formulation of the SIOMS guidelines, which came out in 2016, there was this one simple thing which was suggested, which was that researchers have to now justify exclusion of any population or community or individual. Earlier they had to justify inclusion, right? So they had to say why they want to include, say, pregnant women, lactating women, persons with reduced capacity, etc. The onus of responsibility has to be shifted actually to sponsors and researchers, and they have to be questioned if they actually end up excluding any group of individuals in the name of vulnerability. Because if we don't do research with so-called vulnerable populations or groups or communities, how are we ever going to generate evidence on what works for those communities and individuals? And I think it is extremely important, as we've seen through the pandemic as well, whether it be interventions such as drugs, whether it be vaccines, whether it be public health interventions, we do need that evidence for communities, and especially so for those groups which might be traditionally marginalized. So I think just simply justify, why you are excluding someone, and the usual norm should be inclusion for everyone, including those who we consider vulnerable.
Thank you, Anand, for that. So I think that's covered the first question. So moving on to Chetna, a question for you. From your work with children, and just 1 minute, I'll just get this on. From your work with children, what would you feel that researchers need to bear in mind when in this issue of capacity when you work with children across different ages? That was one. And as a therapist, you've also worked with disadvantaged communities. And you earlier brought about the point about, vulnerabilities being multi-layered. Again, what would you suggest that researchers need to keep in their mind on this issue of capacity? Over to you, Chetna.
Thank you. I'll try to cover this across 4 or 5 aspects. And I think this is one of the most enduring and widely discussed aspect of research in children, which entails this aspect of consent. And there are multiple threads that actually come into this. One is, of course, this aspect of vulnerabilities and capacities. So are we talking about vulnerabilities or capacities in children? And, while there's been this premise that children don't have cognitive and emotional capacities to make decisions, there's also been the other discussion about how children do have, evolving developmentally the capacities to make decisions for themselves. So that's a very important thread that we, first need to keep in mind when we are looking at consent with children, particularly children who are seen as, a vulnerable group, and issues of consent come in. So developmental frameworks become really important when we are looking at consent with children, because children are developing this autonomy and maturity. And the other sort of intersecting thread is also about rights of children in terms of their right to self-determination. So these kind of intersecting threads come in when we look at consent. Of course, for children, we know that, there are some guidelines in place, like ICMR has guidelines that, if you have children below 7, we don't need to take assent, and then 7 to 12, you can do with an oral assent, and then if the child is 13 and above, you can actually take written assent. And the parent is someone who actually can give consent for research. Now, that also brings in that aspect of what are the specific roles, obligations, and rights of parents when it comes to consent, giving consent on behalf of the child. Of course, there's been a lot of discussion also about the fact that with adolescents, with their growing autonomy, can they give their own consent? And I think now there's clear recognition on the fact that needs to be acknowledged. And there are certain studies where there can be waivers as well for parental consent. So there is definitely the framework in place. I just want to highlight a couple of things about this issue of taking assent and what happens, when dissent comes up. So in terms of taking assent and in the work that we've also been doing with children, what I want to say is that assent is a process, and it needs to be understood not as a document, but something which is ongoing as a process, which is two-way. And it allows not just for, just giving consent, but some space for contemplation as well. So there are certain things that we might need to keep in mind. One is, of course, the developmental age of the child. And there's been more and more discussion on the fact that even children who are below 7 years of age, even if there is no assent required, assent should be part of the process. And we can find developmentally appropriate ways to actually build assent into research for children. So people have spoken a lot about developing different methods, creative approaches, using storyboards, puzzles, different ways in which children can respond to actually give assent, even using ways to, have them figure out different aspects of the research, and using visual memory aids. And people are also talking about the fact that children with different abilities and children with different needs and linguistic capacities can also be assent can be taken in very, very creative ways. What is also becoming important is the fact that the process of assent has to create safety and trust in children. And most importantly, this doesn't sort of stay limited to the question of competence, but is based on the principle of respect. That if you are respecting a child, how would you ensure that the information is given to the child and the child feels a sense of safety in the research process? The other thing that I wanted to highlight in this context is this aspect of power that comes in between the researcher and the child, because usually the researcher is someone older. And when language comes in, there is immediately a power differential. So are we sort of self-reflexive about the way power is playing out when we are taking assent? And one of the important things in working with children is also perhaps to think about, does the child know how they can actually refuse participation, because sometimes children might think that people will get upset or angry if they don't participate in research. So have we equipped them enough with ways in which they can actually dissent? And I think this is an important area where people are speaking a lot more about recognizing that with children, the dissent doesn't have to be explicit or verbal. It can be in different ways that a child might communicate dissent. And as researchers, how do we pick that up, whether it's in terms of silences or saying that they don't know, or if they are wanting to leave and go to their parent? How do we respect those decisions? And how do we even recognize signs of distress? So this becomes another very important, crucial aspect with children, because sometimes children who have experienced trauma or neglect, or might have experiences of abuse, or adolescents who are very vulnerable because of experiences of high distress or self-harm, being maybe trauma-informed or being cognizant of the fact that the child might need support, those aspects become very, very crucial. Just another small point that I want to add is that, there's obviously a contextual cultural layer to this, that, when it comes to certain contexts and cultures where parents, if they have given their consent, that, can children actually go against that consent? And, in some contexts, children actually have more opportunities of education and they have more exposure than parents themselves, and they might be much more aware. And in some contexts, that communities that we work with, people who are below 18 are actually married and have children of their own. So what really happens in those contexts? And I know we might not have time to look at the entire landscape, but just wanted to highlight that, we are not looking at one homogeneous population when we're looking at children. It's really diverse, and for us to perhaps keep this in mind when we are thinking about assent and consent in children.
Thank you, Chetna, for the short time. You've really given us a landscape view of the area. Thank you so much for that. Anant, would you like to give us your insights on this issue of children and capacity and involvement in research?
Sure. I mean, I think, Chetna did a great job with highlighting some of the key issues. One thing I would like to add on is also sometimes our insistence on safeguards, or our assumptions on safeguards might also make it more difficult for especially young adolescents to access care. And this is especially true of mental health. We recently did a paper which was led by a colleague, Pavitra from SCARF in Chennai, and they've been working with a lot of at-risk adolescents in urban settlements in Chennai. And a lot of these kids will not agree for their parent to be involved if you have to have them sign off from consent perspective. So that would mean that especially adolescents who might be just about perhaps starting to face mental health issues, and we all know that early onset is one of the risk factors for longer term chronic mental illnesses. Unfortunately, the insistence that we have that only a parent can take decisions for the child or the young adolescent in this case might actually end up being a barrier for accessing mental health care. So this is where the importance of nuance becomes important. And I think mental health professionals probably struggle with this because, you have legal obligations around, you have this cutoff around 18, but there is nothing magical about 18, as Chetna was saying. You might have mature minors, you might have individuals who have thought through why they need to access mental health care and are actually reaching out. But it is us as clinicians, mental health professionals, and researchers, if there are community research activities happening, who might actually refuse them in the garb of requiring, parental consent or a legally acceptable representative or a nominated representative under the Mental Health Care Act. So that is where I think all of us need to think through what is the right approach here. If you clearly have a young adolescent who has a need, has reached out and wants to access services, but we are not able to provide them because we want some kind of a legal safeguard in place, which is the consenting in of the parent. And is that actually a solution, or is that actually problematizing it further from a mental health perspective? So maybe that is something where we need to certainly do more creative, pathways to try to ensure that we are able to work with such kids, perhaps ensure that risk is minimized, they are protected, because that is what ethics is all about, right? It is not about the signature on the form. It is about the best interest of the individual and how we can ensure that the risk for them is minimized. Maybe there are alternative mechanisms which can be explored, including, of course, assent and ensuring that the kids are understanding what they're signing up for. but yet not insisting on pathways which they are not comfortable with.
Thank you, Anand, for raising that important point about a safeguard. Hannah, if I can ask you to come in now with what would you like to tell us about your own experience? Have you had to work with children, adolescents, or people with other dual vulnerabilities, other than mental illness, other vulnerabilities? Can you share your take on that?
Well, I don't have experience working with young adolescents or children, but similar situation. I mean, I was thinking when they're talking this concept of guardian. It's not. I mean, there is no legal concept of guardian in our context. So I was thinking, if it was in our setting, we we have to make sure that the guardian and the caregiver who's giving consent is the right one and have the right intentions for the participants. So that came to my mind.
Thank you, Hannah, for that. I think that was really helpful to know that point. Now, the question for Anand, from an ethics viewpoint, Anand, why would you say that this issue of capacity is important, especially with patients with mental illness? And what do you see are the particular vulnerabilities of patients with compromised consent, especially in India and across the world, really, but especially in your work in India?
Sure, thanks, Sunita. So, I mean, one thing, both in relation to vulnerability and capacity, is that increasingly we've all come to the conclusion that none of this is static often, right? So very few, if any, individuals are probably going to be always vulnerable or always having challenges with competence. I mean, with even patients with serious mental illnesses such as schizophrenia can have lucid moments or periods, right, where they are perfectly able to engage and perhaps comprehend and respond to outreach around research or participation in clinical care. Now, there might be various reasons why there is compromised capacity. There might be issues around health literacy, for example. And there, the onus, of course, has to be on the research teams to ensure that if there is a deficit, that deficit is crossed. Of course, that will require that as researchers, as sponsors, as institutions, we invest the time, we do community outreach, we do participant outreach, we engage with them, and try to figure out what are the right pathways to ensure that the key information which needs to be transmitted is done. Because ultimately, at the end of the day, what is consent about? Consent is about the knowledge, but also ensuring that it is comprehended, ensuring that there is voluntary decision making, and supporting them through all of these pathways, and ensuring that there is some way of documenting it. Now, all of that requires some level of effort, right? And as we always say in consent, hence we have to move away from the focus on the signature and the form and more on the process. And if that is true, then even with patients with mental illness, you would recognize that if there is more longer term engagement with the patient, with the individual, there would be pathways to try to get an understanding which is mutual in nature, so that they understand what you are trying to do, why it is important to them, why is it that they are participating or are being asked to participate in the research, and get the right information sort of communicated, and ensuring that this is done in a way that there is a reasonable level of confidence, both for the researcher, but perhaps also the ethics committee, which wants to make sure that you are taking off that box, that they have understood what they are participating in. Now, add on some other additional layers. This was something Chetna was talking about, for example, marginalization, intersectionality, and stigmatization, right? Because it's usually also the case that when there are historical inequities and marginalizations, that individuals and communities might be reluctant. Now we might sometimes choose the easy pathway of saying that they're not competent or they are vulnerable, but it is actually trying to understand the larger sort of social inequities or context due to which those vulnerabilities exist, and how that might also hence impact their ability to be able to express an opinion about whether they want to participate or not. So perhaps that is where some of those nuances become important as well. I think as the Mental Health Care Act suggests for us in India, the presumption should be that all persons with mental illnesses have the capacity to consent. And it's actually for the health providers and the health researchers to prove otherwise. And that interpretation, I would tend to think, needs to be much more liberal, in the sense that we should actually try to be as inclusive as possible. Because at the end of the day, if we want to take a rights-based approach to mental health and also to research, then we have to try to ensure that the participant who is at the center of that engagement is truly being made to understand what is happening to them and why it might be in their interest to participate, and finally leaving that decision to them, and do whatever is required for that, whether that be the involvement of a legally acceptable representative or a nominated representative, whether it's getting other individuals in their social circles who they might be more comfortable with. These could be, for example, true of for individuals who are from sexual minorities, who are not in comfortable relationships with their filial families. They would rather like to have a partner or a friend be the person who's helping them process this information about participation, etc. So how open are we to that is something we need to look at. But suffice to say that I think there is increasingly the case for us to be actually trying to enhance the way we look at consent, to be more inclusive in nature, and put the participant back to where they belong, which is at the center of the discourse, rather than us taking decisions on behalf of them, that X person is not competent, and hence I, as the provider, am going to take a decision on their behalf, or I'm going to get someone else involved as a guardian or as a legally acceptable representative to take a decision on their behalf. Because I think that's where we perhaps err sometimes, in the name of caution, but perhaps not being keeping again a rights-based approach at heart.
Thank you, Anant, for that. So, Hannah, can I ask your opinion on, from your own experience, hands-on, what did you feel, or from the work that you've done? Why is this issue of capacity so important from an ethical viewpoint?
So it was important because we were working with people who had severe mental health conditions. Working with people with mental health condition always raises ethical issues, and working with those who lack decisional capacity is even more worrying. So, of course, we had to make sure that they were not refusing to participate. We had to make sure that they were not forced to say, of course, they didn't have the capacity, so they couldn't say yes or no, but if they were not communicating unwillingness, we sought consent from their caregivers. But we had to make sure that they were informed of their risks, and we had planned to reassess their capacity in between time points, assessment time points. But still, there were limitations because those who were delivering the care were not communicating their capacity to consent in between. That was not done. This was one of their limitations we had faced. So, of course, and then there is another ethical issue because we do not have mental health legislation. So, of course, when they agreed to participate in the study, it meant that they had to agree to the treatment as well. Of course, they were not forced. If they discontinued, we did not force them. They were still invited for the time point assessments, for the outcome assessments. Another ethical issue, we had to safeguard for those who had capacity in the beginning. We had to ask for an advance directive if they lost capacity subsequently, if they were willing to continue participating in the study. So there was this issue as well, because if they lost capacity in between while they were in the trial, we had to make sure that they were willing to continue after if their caregiver gave permission. So we had these ethical issues, and we had these plans to safeguard them. Of course, there were limitations.
Thank you, Hannah, for that. So Chetna, could I ask you your opinion on this question?
Sure, I think a lot has been covered, but I think I'll go back to that point on the fact that consent is not a static process that Anant actually started with. And I was just reflecting on, how we talk about obtaining consent. It's like almost like you go and you obtain it and you come back. And I think maybe sometimes even thinking of the terminology is helpful. And not from a cosmetic point of view, but from really seeing that, what does it mean to receive that consent from somebody? And do we respect that consent? And therefore it's a process, and does that begin only at the time when I actually start collecting data, or have I actually thought of it, build it into my methodology, or maybe included people from the community in even planning how this consent needs to be obtained? And those are, of course, one set of questions. The other thing that I was thinking about is that this aspect of consent being just at one moment in time, at the start of the research, versus something where we take moment-to-moment permissions as well. I might give consent saying I want to be part of the study, but once you start asking me those questions and I start going through some aspects of the research, I might not be so sure of my participation. And the fact that, while we say right to withdraw, but I think really also checking moment to moment with the person if they're okay for them, for us to continue, rather than assuming that they've said this and we continue doing what we're doing. And I was just wondering that for building this sort of a dialogue, what we might also require in research spaces in terms of reflexivity as researchers, and also some safe spaces for us to come and communicate these ethical dilemmas that actually come up for us when we are actually in the field. And I found that becomes a very helpful space, because sometimes these are just emotional responses we might experience. These are sometimes implicit messages. Only when there are spaces and people are able to articulate and come back and say, oh, this is what I experienced. And there are safe spaces even for researchers to come and think about. Maybe then they're able to articulate that dilemma and also perhaps go back more sensitively to the research participants. And maybe those are also moments where they are able to reflect on their own identities, how they are actually coming into play into research, how that is actually linked to the social identities of the communities they're working with, and what sort of positions of power and privilege are playing out within that research. So I think that perhaps those could also be some ways for us to think about this.
Thank you. I think that's an important point about having a safe space. Got that. I'm very cognizant of the time. I think we've had the panelists really answer the questions and give us deeper insights into this topic. So we'll take questions from the audience. So we have Purnur Kaur, who's asked, what is the role of providing incentives for participation in mental health research? Is it ethically sound? I'll ask Anant if you can answer that, and then if the other participants other panelists want to ask.
Sure, thanks, Purnur, for the question. So I think that's a it's an interesting question, because in classical ethics approaches and research, this whole idea of incentives has always raised alarms, especially for ethics committees. Why are you giving incentives? What is the amount of the incentive? What is the benchmark you're using for the incentive? Will this actually lead to coercion? Will this lead to an expectation in the group of individuals and our communities about what you're going to do in the future? Now you have to balance that with the other set of requirements as to why you should be incentivizing, right? And sometimes it might be simple things like people are spending time in your research site waiting room, so you want to reimburse for that time, whether lost wages or transport, etc. But more importantly, now there is a whole sort of class of research which focuses on the incentive as being part of the intervention. So that is a fine divide, which I think is extremely important. So for example, if your intervention is, if we incentivize persons with mental illness, is it more likely that they will be adherent to treatment? So that it's not just whether they stay on medication, but you also then have some kind of either a monetary or a non-monetary incentive. Now that kind of research brings in its own ethical issues, but I think is important for us to explore as well, because what we try to do ensure that individuals have access to services or to treatment. So I think it's not radically different, the kind of ethical issues which will arise when you are talking about incentive for, say, mental health research, but perhaps incentives are also sometimes more of a requirement for marginalized communities, including persons with mental illness, because again, they are less likely, for example, to have jobs. They might have less social support available. So for them to be able to actually spend time with you in your research study will require for them to be supported. And for that purpose, I think perhaps there is even a stronger ethical case for incentivization, but what extent, what amount, etc. Of course, that is something for the research teams and the ethics committees to engage about. But I think we should certainly keep the realities which individuals have in mind when we make that decision, and be more liberal about them.
Thank you, Anand. Hannah, I'll be able to give you only about 30 seconds, but would you want to add anything to what Anand has said about this issue of incentives?
I think Anand already raised some important points. There is a fine line between, like, is it going to be coercive or not, and if they find it beneficiary, or I mean, this issue was raised in our study as well, but we had to be careful. I mean, on the amount of incentive, that it only covers their transport or their time, or if they have to spend lunchtime with us during the assessment time. So of course it's tricky sometimes, but we still need to incentivize participants for spending time with us. And I think it will, there is no black and white answer when it comes to this issue. That's what I think.
Thank you for that. Chetna, 30 seconds for you, because we're a bit over time, so we just need to close soon. So anything on incentives you want to add?
Very quick thought. This gets even more complicated when we're looking at children's research. So just wanted to add that, if you're giving an incentive to the parent, what does it mean? Parent giving consent and things like that. But I think rest of it has been covered in terms of how do you balance it out. So won't go into that.
So I know we're over time. So I just request each of the panelists to just in 1 or 2 points, to if there's something particular they'd like to reiterate to the audience, or something which is not covered, as 2 quick take-home points. Anand, I'll start with you.
Yeah, just to quickly say that, again, at the heart of it all is inclusion. If researchers, sponsors, ethics committees, and mental health professionals can try to ensure that, that would be important. And let's bring the participant at the center of all of our engagements in this. So if we do that, I guess we'll all be better placed in discussions like this. Thank you.
That's great. Chetna?
I'll just layer on Anand's idea of inclusion and say that, vulnerabilities are very complex, and for us to also recognize that whatever vulnerabilities our participants come with, we can actually add to those vulnerabilities. So to be also sort of mindful of that. Yeah, I think just sort of put protocols in place to be able to take care of it. Yeah.
Thank you for that. Hannah, can you tell us couple of take-home points for us?
Yeah, they've said it all. So I'm going to say that inclusion is very important. Such population need the care as well, like the other population. So we just make sure that the safeguards in place are adequate. Thank you.
Great. So I think we're just 3 minutes over, and I think we started about 4 minutes or 5 minutes after time. So I think we've done well. So a big thank you to the panelists for giving their time and expertise. And I think Hannah, Anand, and Chetna have really taken us through not only why this issue of consent in patients with compromised capacity is important, but why it's important to include them so that we generate evidence-based data, for this group. And both in terms of mental illness or dual vulnerabilities, disadvantaged communities, and children. And it was really great to hear from the hands-on experience that all 3 of them have had. So thank you very much for this. And I hand over the mic back to the organizers.
Thank you, Sunita, and thank you, Chetna, Anand, and Hannah, for joining us. It was very helpful for you to have broken down the consenting process and to speak about practices that are not only relevant for populations with compromised capacity, but also more generically too. With that, we'll take a break. We'll be back at 6 p.m. for the last session for today, which will be delivered by Geeta Sen. So I will see you all in 6 minutes. Thank you.
Thank you.
Welcome back to the final session for today. This session is going to be delivered by Geeta Sen. The title of our final session is Equity and Diversity in Global Health Research, Countering Imperialism. This session is being chaired by Abhijit Nadkarni. To briefly introduce Abhijit, he's an addiction psychiatrist and global mental health researcher. He's an associate professor at the London School of Hygiene and Tropical Medicine. His research interests encompass global mental health and particularly alcohol use disorders. A lot of his work is based out of Sangat, a research NGO in Goa, where he has started and led the addictions research group. So I welcome Geeta Sen to this session, and Abhijit, over to you.
Thank you, Rita. Oops, sorry. Gives me great pleasure to introduce the last speaker for the day. I think it would be a bit stereotypical to say we kept the best for the last, but I wanted to thank you, Geeta, for making it today. I understand that you have been unwell, and despite that, you have made a great effort to be with us. We truly appreciate it. And I would just like to do a quick introduction for those of you who might not know Geeta. So Geeta has over 40 years of experience of working nationally and internationally on gender equality and women's human rights. Her work has ranged widely, spanning poverty, population policies, human development, labor markets, and women's health. She's currently a distinguished professor and senior advisor of the Center on Equity and Social Determinants of Health at the Public Health Foundation of India. And she has for many years been a professor of public policy at the Indian Institute of Management, Bangalore, and adjunct professor of global health and population at the Harvard THN School of Public Health. She's been a member of the governing body of the National Health Systems Resource Center, the Mission Steering Group for the National Rural Health Mission, and the high-level expert group on universal health coverage set up by India's Planning Commission. I don't think I need to say anything more to establish her credentials for this talk. So without much ado, I hand over to you, Geeta, to take this session forward.
Thank you so much, Abhijit. Just want to check that you can hear me.
Yes, loud and clear. And Sharanya and Vijay,
great.
could you put the spotlight on Geeta, please, and take it off me?
Okay, just to say a couple of things to start with, because we may have a few glitches. I am actually isolating because of COVID, and I have my, it's the fourth day I don't have fever, but I'm certainly infectious, I'm sure. And I have my 94-year-old mother at home. So one of the challenges we may run into is that the room that I'm isolating in is not the best one in terms of internet accessibility within the house. So, but I can't do anything about that. So I may, in fact, what is going on?
So, Geeta, if you're going to share your PowerPoint, yeah, we can hear you.
No, I don't have a.
Okay,
I don't have a PowerPoint.
Okay.
I'm going to stop video because hardly had I said what I was saying when all hell broke loose on my laptop. So I'm just taking off the video, and now that you know. In case I get knocked off, just hold on. I will come back. Let me start by just saying thank you to the organizers. I'm really honored and very humbled to be asked to give this lecture. And humbled especially because I'm not a mental health expert. Though I have thought quite a bit, or should I say worried quite a bit, about the connections between equity and bioethics. But in a sense, this lecture has given me the opportunity to think about some of those concerns in the context of mental health. And I would love to try it out on you and see what you think. But first, let me say something about what, oh God. Okay, I am going to have to shut down and come back in. There's something really wrong here.
Geeta, we can hear you quite clear.
I know, but I can't read my read my notes. Okay, it seems to be settling and going back. I don't know what the problem is. Okay, so first, let me say something about the second part of the title of this talk, which is Equity and Diversity in Global Health Research, Countering Imperialism. And this was sort of the rather small topic that the organizers gave me. And I've been trying to put all of it together. So let me first say something about what countering imperialism may have to do with any of this. I'm very aware, and I'm sure most of us are very aware of how imperialist the research project is. Not only health research, but research in the social and natural sciences more broadly. We have overwhelming evidence of unequal and unfair divisions of research labor by ethnicity, nationality, gender, caste, you name it. We also have data and evidence of data and evidence theft, thinly disguised as collaboration, or worse, as open access. We have evidence of hugely disproportionate lack of presence of Southern researchers or women researchers, or you name the subordinate group, and you'll find it there, in research panels, committees, and so on. And sitting above all of it, the poor attention to the diseases and ill health and their social determinants for poor and subordinate or subjugated peoples. We have less evidence for how disciplines themselves enshrine imperialism at their analytical core. And I'm going to come back to that, what I consider very pertinent concern, a bit later. That is, what's the worm at the core of the research, of the disciplinary apple that then gets picked up and translated in research. Again, before I do that, let me turn to inequality itself. First of all, and I don't need to tell this group that, you're very aware of it, there's a growing understanding that inequality, like just about everything else, is intersectional. This means, among other things, that not all subordinate groups are the same. It means that I, for example, have been able to leverage my advantages as upper caste and of medium economic position to compensate, even if it's only partially, for my disadvantages as a brown woman from the global south. Addressing intersectionality and not only economic inequality is central to countering imperialism. And we recognize that very clearly. And I, as someone who's been working on equity and equality issues for a very long time, know it's actually not that long ago when people thought you could just talk about differences between households which had no other characteristics than their economics, income and wealth, and that you would have addressed the challenge of inequality. This challenge of inequality has been brought home in spades by the obscene inequalities in access to diagnostics, vaccines, therapeutics during COVID-19 itself. An inequality driven by a lack of solidarity and genuflection by the powers that be to the demands of big pharma. But countering imperialism goes deeper than this. Why do I say that? Decolonization, as we know, is a buzzword today, and it runs a serious risk, I believe, of becoming completely empty rhetoric. And as I was thinking about this challenge, it took me back to my early 1970s training for a PhD in economics at a US university. The anti-Vietnam War protests were at their height. College campuses were on fire. I began learning as a student about the thick history of US imperialism. European colonialism was what I was more familiar with up to then. All of the wars, the interventions, the coups and dictatorships, the toppling of elected progressive governments, and so on. At the same time, we as students were struggling within the economics department against neoclassical economics and for a more radical understanding of the world's political economic past and present. You know, anthropology as a discipline has been called the handmaiden of colonialism. Neoclassical economics, you could say, is the foot soldier of neocolonialism and imperialism, the perpetual accumulation of more and more wealth through the poorly disguised plunder of the South and greater inequality, all done through economic logic, laws, and institutions, and less by the crude conquests of the colonial period. Although, of course, we must never forget that the iron fist of military power is always present inside the velvet glove of laws, institutions, and so-called economic rationality. At the heart of this challenge was this idea of economic man, Homo economicus, economically rational man. But rationality was always defined as equivalent to selfishness and greed. Selfishness has been deified in innumerable theorems of welfare economics. The coming together of selfish individuals in the marketplace is supposed to lead to the welfare of society and of everyone within society. For us, progressive students searching for a more meaningful political economy-based understanding of the world, countering imperialism meant as much challenging this worm at the core of neoclassical economic theory as it meant opposing imperialist wars and military coups. And it is a worm. This idea of selfishness and the related inequalities of a globalized, financialized economic order as being rational. Because perennially selfish individuals within a more and more unequal system cannot really work together to change an economic system that is clearly taking us beyond the tipping points of climate change, or enable us to address the problem of obscene economic and other forms of inequality, including, I will argue, health inequality, with genuine solidarity. So why am I telling you all this? And what does it have to do with today's topic? 3 reasons. Let me just check in. You can hear me, right, Abhijit?
Yes, loud and clear. Please.
Okay, great. Yes. For 3 reasons. First, because economics is and has been the lead discipline in social sciences in sanitizing and naturalizing inequality. Where economic theory and methods go, other disciplines, and notably political science and sociology, follow. This isn't a source of pride for me, but of actually grave concern because of the disciplinary contamination that that leads to. Second reason, because Homo economicus, the selfish, greedy individual at the heart of neoclassical economics, is simply a fiction, an assumption with zero basis in human psychology or any empirical evidence about actual human behavior or what drives it. And third, because it is mental health and public health research with a focus on bioethics, equity, and diversity that brings this out very clearly. And that obviously is what I'm going to turn to next. Let me just put in one caveat. If there are any economists among you, you may feel tempted to jump up and down and say, no, what are you talking about? There's all this new work in so-called behavioral economics that has pushed economics to begin looking at how people actually behave instead of simply positing that everyone is selfish all the time. I would argue that this is good, but it's relatively recent work. It's very much on the margins of the discipline, and it still remains almost painfully individualistic in its approach. So let me move on then to talk about inequality, mental health, and bioethics. I'm going to begin with the quote from Richard Wilkinson and Kate Pickett's second book, The Inner Level: How More Equal Societies Reduce Stress, Restore Sanity, and Improve Everyone's Well-Being. The book came out in 2019, about 10 years after their first book, The Spirit Level. The quote is, "One of the most important but largely unrecognized features of human social organization is that for about 95% of the last 200,000 to 250,000 years of human existence, with human brains being their current size, human societies have been assertively egalitarian." So we have the misfortune of living in that 5%, which is the unequal, non-assertively egalitarian form of social organization. That is, humans are not naturally or inherently selfish. Human psychology is a product of social organization, among other things. It's not the only thing that's at work, certainly, but it is important to recognize what role social organization plays. Now, Wilkinson and Pickett, and this you can take with, a handful of salt if you like, but they argue that there are three periods of social organization very broadly. Since the apes and the chimpanzees, the pre-human dominance hierarchies with a usually male dominant leader and then a hierarchical system, followed by human egalitarian hunter-gatherer societies, about whose egalitarianism we have much more evidence today than we had when I began studying economics. And thirdly, the hierarchical agricultural industrial societies, which we live in today. And they make this point about three periods in order to make the point about our needs, our desires, and our behaviors as being socially malleable. They put together a wide range of anthropological, ethnographic, psychological, and epigenetic studies and evidence to argue not only that socioeconomic inequality is bad for our physical health and well-being, but that it is bad for our mental health through a number of pathways, chief among them being stress levels. Now, let me emphasize something here, which is also very much a point of their work and it's a point of my work. We're not talking just about absolute levels of deprivation. A society in which everybody is more or less at the same level of poverty or deprivation does not have these kinds of problems that they talk about. It is the inequality that does it. And some of their evidence is fascinating. For instance, apparently women in more unequal societies prefer more masculinized faces. So if you show women in an equal society versus an unequal society, pictures of men looking very male and macho versus men looking like men normally do, a mixture. Women in the unequal societies seem to prefer the more masculinized faces much more. Fascinating evidence. What's going on in their heads? They also argue that there is evidence of much more childhood bullying in unequal societies. And of course, as we would expect, higher stress levels among poorer people and subordinate groups because there's more fibrinogen in the blood and thicker blood concentrations because they're in perennial flight or fight mode in an unequal society. Significant epigenetic differences between not individual, not random groups, between socioeconomic groups within the same society. That is, gene expression, which genes are switched on and off, seems to be affected by socioeconomic inequality. Children and adults, and this we know, are not only treated differently if their social or economic status is known, for example, their caste, their ethnicity, their gender, etc. But, and this is the kicker, themselves behave differently. For example, performance in tests, they underperform, interviews, etc. Whereas if nobody knows who they are, and there's lots of evidence of this, blinded, double-blinded test results and interviews, all kinds of things. Little difficult to double-blind gender, but you can do a lot of other things. And it keeps showing up. They're treated differently. Subordinate groups are treated worse, and they themselves perform worse than they would when their background is not known. Now, there have, of course, been critical reviews of Wilkinson and Pickett's books, and I won't get into the details of what could be some of those. But for me, what is important are the persuasive links they draw between inequality and mental health, and between inequality and cooperative and solidaristic versus selfish social norms and individual behaviors. And if there are any economists among you, by the way, I would say that the behavioral economics evidence is going in the same direction. Now, in the rest of what I'm going to say, I'm going to build on a couple of other talks I've given recently. The Yusuf Hamid lecture that I gave in 2020 called "Is Inequality Toxic for Public Health Agendas?" A recent talk at PHFI colloquium called "Inequality as a Social Determinant of Health," and a lecture on inequality that I gave at the Institute of Public Health in Bangalore. I'm saying this so that people who may have attended any one of those would know that I'm really trying to build off of those. I'm intending to extend those in the direction of mental health. Now, there are three manifestations broadly of health inequality that we know. Health outcomes in both physical and mental health, differential vulnerability and risks due to social determinants of health, and inequality in access and affordability of preventive, promotive, curative, restorative health services. Now, I argue, and I believe there are 5 evidence clusters for the relationship, 5 clusters of evidence for the relationship between health and inequality. And this is both physical and mental health. And you'll see where the mental health comes in. So the first cluster is the type of inequality that we're all very familiar with, economic and wealth inequalities. So there's a large body of evidence, as we know, in both high income and low and middle income countries on the health impacts. That is, health impacts, not gradients, not just threshold levels, as Michael Marmot pointed out long ago. on the impact of income and wealth inequalities. Wilkinson and Pickett's stress, fibrinogen, and the links to depressive disorder evidence suggests that it's inequality, not absolute poverty or absolutely either in terms of income or wealth, that is to blame. In India, for instance, this income and wealth inequality has gone through the roof in recent decades. From 1961 to 2020, the wealth share of the bottom 50% fell from about 12% to about 6%, while the top 10% went from 43 to 64%, and the top 1% went from 12% to 32%. And this, of course, has happened since the globalization, liberalization revolution of 1991 onwards. The critical questions this raises for us, given particularly what is being said about the relationship between inequality, stress, and depressive disorders, is what do these significant increases over the last couple of decades in income and wealth inequalities across the globe and in India imply for mental health outcomes? What does this mean in terms of vulnerability and exposure to ill health causing factors? And what, if anything, does it mean for access and affordability of health services? Or are we covering ourselves in a rhetoric of programs to strengthen the so-called human rights basis of health? And actually, it's like the proverbial mop that is trying to mop up the flood released by the inequality taps that are wide open. The second cluster of evidence is about social inequalities. And this is where a lot of my own work has been particularly, or it's been actually between the intersections between social inequalities and economic inequalities. These are group-based inequalities, whether of gender or of caste or of race and ethnicity, of religion, of disability, of migrant or refugee status, of geography, sexual orientation, gender identity, and the intersections among them, and economic inequality. Many of these group social inequalities, as we are painfully aware in India, with both caste and gender and increasingly religion, are actually due to a society's what we may call original sins. These inequalities are the persistent hardy perennials that are extremely slow to change. And they result in a range of phenomena that affect health: discrimination, othering, stigma, explicit and implicit biases of different kinds, as well as physical, mental, and sexual abuse, and violence and fear of violence. As Wilkinson and Pickett said, there's more evidence of childhood bullying in more unequal societies. And now we have a 2018 study by you in 122 countries using GBD, Global Burden of Disease data, whatever one thinks about GBD data, that found significant associations between gender disparities in depressive disorders and socioeconomic measures of gender inequality. The effects on health due to social inequality, are they different from additive, multiplicative, intersecting from the effects of wealth and income inequalities? Secondly, the consequences here include, among other things, exclusion, discrimination, and non-recognition of the health problems of groups that are at the lower end of social hierarchies. The deep presence of social inequalities and their intersectionality with each other and with economic inequalities. Not all poor people have the same health outcomes. For example, just take poor men versus poor women. An intersectional lens raises a plethora of new questions and concepts, like the leveraging issue that I raised right at the start. Some groups that are in the middle are able to leverage, even though they may be disadvantaged, are able to leverage some of their advantages to compensate for others, while others that are disadvantaged along too many of these socioeconomic determinants simply cannot. The third cluster of evidence is about status inequalities as different from social inequalities. And this comes from the work of social epidemiologists, the imbalances between life challenges and capabilities, the wear and tear of unfulfilled aspirations relative to others, chronic stress, again, frustration, anger, anxiety, social pain of exclusion, which engages, by the way, the same parts of the brain as physical pain. And this manifests in both kinds of things, in resistance to oppression, but it also manifests in millenarian groups, othering, blaming others for your own situation, feeling superior, whether it is by race or religion or ethnicity, and a range of ways in which social factors can end up affecting population health. And during COVID-19, we've of course seen many of these. The fourth cluster is what comes from psychoneuroendocrinological processes. This is the fourth cluster of evidence. It has its roots, as we know, in psychosomatic medicine, a lot of the work on allostatic load, and most recently, there's been a systematic review in 2020 by Guidi et al., which is a review of finally 267 papers, so not a small number, that found significant implications for health through these processes. Chronic stress alters the regulation of the endocrine system, as those of you who are doctors know better than I. In altering the way in which the various glands, the hypothalamus, the pituitary, adrenal gland pathways work together, it can lead to hypercortisolism in the system, which then has an impact on nerve endings and so on. Early adverse events and continuing adversity in people's lives and inequality, such as separation, sexual abuse, chronic oppression, such as what women, Dalits, and African Americans in the US might face, can result in triggering these kinds of pathways, and they result in adverse and harmful behaviors, which then get put down as poor lifestyles, such as smoking, substance abuse, dietary problems, etc. There's a rich and growing body of evidence, and the review, systematic review I just mentioned by Guidi et al., found significant links between allostatic load and a range of NCDs, depressive and other mental disorders, cognitive decline, and physical frailty and harmful self-harming behaviors, as well as spillovers into epigenetics. And that's the last cluster of evidence I want to speak about, epigenetic factors. These changes, epigenetics, as again you know, are changes that are due not to changes in the genetic code, and this is extremely important for what the countering imperialism focus for today, but changes in the way in which genes are expressed, that is which genes are turned on and off. Poor diet, undernutrition, living and working in toxic environments, but also stressed lifestyles, stressors coming from the workplace, social stresses of different forms of gender, caste, ethnic, other forms of inequality and power can all lead not just to ill health through direct exposures, but also through epigenetics, affect the child in the womb, or transgenerational effects by affecting the oocytes in the fetal ovaries themselves. Emerging research tells us that these effects can go across multiple generations. And that epigenetics means that there are risks for cognitive disorders, diabetes, cancers, etc., can be transmitted in this way. Early childhood social experiences and inequality may trigger changes in gene expression. There are significant epigenetic differences between socioeconomic groups. And interestingly, however, animal studies suggest that altruistic behavior, and I suppose selfish behavior also, can become genetically expressed. That is, there may be a selfish or an altruism and solidarity gene that gets turned on and off. I mean, that's a crude rendering, but I'll come back to that issue in a bit. Important to note, most important to note, I would say, is that these are reversible because it's gene expression, not the genetic code, although it may take generations. Selfishness and lack of solidarity may not be completely who we as humans are. So the conclusions from the evidence clusters quickly. First, inequality casts a very long shadow within societies and over time on physical and mental health and well-being. Second, economic inequality is only the tip of the iceberg, although it's a mountain-sized tip, I admit. But I insist that it is only the tip of the iceberg. Just give me a minute and just get a sip of water. Third, social inequality, including intersectionality, can contradict what economic inequality may tell us. For example, we have something called the weathering hypothesis, which I haven't gotten into, but if someone's interested, I can tell you about it. Fourth, status inequality can help us understand individual and group behaviors, including health-related behaviors, such as the opposition to masks, the phenomenon of blaming those who are in fact making efforts to counteract this pandemic. Fifth, psychoneuroendocrinology is advancing our understanding of chronic problems unequally present in society. And reproductive epigenetics has moved us beyond direct exposure towards understanding inter- and transgenerational effects. So very quickly then, the inequality pathways to health. What are the pathways from inequality to health? Inequalities, differently from disparities or differences that may simply be due to non-inequality based physical or genetic code differences, imply relationships of superior and inferior. That's the problem. That's the heart of the problem of inequality. Inequality means someone is superior, someone is considered inferior. And those above do not simply exist in innocent juxtaposition to those below. They can affect their health, well-being, status, opportunities, actions, beliefs, and norms. They have, in a word, power over those below. Those below, on the other side, can also have a number of responses to inequality. They may internalize it, they may resist it, they may attempt to subvert it, they may rebel. But there are risks to each of these approaches in terms of health and in terms of violence and fear of violence. The burgeoning evidence tells us that inequality generates particular forms, norms, and behaviors towards others and oneself that affect health. Selfishness versus solidarity. Problematic and aggressive, some would say toxic masculinity. Depression, physical and mental health, in addition to the standard health measures of illness or wellness. Inequality also affects the context of laws, policies, institutions, and finance through the pathway of greater or lesser solidarity among groups. Greater inequality often means lower solidarity, less interest in those who are worse off, blaming the victims, less willingness to support or finance policy or taxation or other changes, or regulatory changes. The inimical effect of inequality on a society's levels of solidarity is possibly the deepest and most wide-ranging of its policy effects, and one of the biggest challenges for people's health. Countering imperialism means, therefore, challenging the disciplinary barriers that focus excessively on individuals, refusing to recognize that socioeconomic inequality fundamentally affects both physical and mental health. But let me end on a positive note. The positive note from all this is that there is nothing unchangeably natural about selfishness, as neoclassical economics and a whole bunch of social science and other disciplines, including in health, would have us believe. In fact, reducing inequality appears to release what we may call pro-social values and behaviors with positive effects on both physical and mental health across the life course. Thank you for your patience and for listening.
Thank you, Geeta, for that enlightening talk. It's been a tour de force, I mean, despite the fact that you're unwell. But may I request you to put on your video? Can we just test it now so that it just helps us with some interaction, if it's all right with you?
You know, I'm going to have to do one thing, if you can give me 2 minutes, because I think something happened to the connection.
Sure.
I'm going to go out and come back in again.
Sure.
That'll take me 2 minutes, and you can maybe collect questions.
Sure, yeah, sure. While you do that, I'll
maybe
just get some questions from the audience.
Let me do that.
Great. So while Geeta does that, I don't see any questions either in the chat or the question answer window. If anyone would like to either type in your question or raise your hand so that we can get you in and you can ask your question directly. Okay. We got some time while Geeta joins in. The questions? Everyone has had a long day, it's tired. Anyone from the organizing team who has joined? Okay, that's a smart response, Amitra. It was an excellent talk, but we are more in a reflective mode. Okay, Mrinmay, no questions. I just wait for Geeta to join. I've got a question. So how much time do we have? We're at 6:44, so we're around 16 minutes more. Okay, we have Geeta back.
Okay.
Can you hear me, Geeta?
Host has stopped my video. So
oh, okay. Let me see if I can do something about it. Can someone do something about this? Sharanya, Vijay, whoever is there on this call, Mrinmoy, so that we can enable video, Geeta's video.
Yes, we are trying.
Yeah, please. So Geeta, while you've been away trying to reconnect, I have been trying to solicit questions. I haven't got any, but Amrita, who is in the audience, did have an interesting response. She said that it's an excellent talk, and this has got everyone else to reflect on this and kind of think a bit more, which I think is mission accomplished, if you ask me. Urvita has her hand up. I also have a question. So Urvita, you can go first, and then maybe me, and in the meanwhile, some of you in the audience have got questions. We'll take this. Go ahead, Urvita.
Thanks, Abhijit, and thanks, Geeta, for that excellent talk. I have no idea how you did that despite being unwell. So really appreciate it. So I had a question about both the decolonizing global health as well as a global mental health movement. There is a common view that we need to shift power to local communities and to aim for local ownership. But there are often no clear plans on how to make this a reality. So do you have any, how do you see this changing in the future, and what recommendations would you have so that we are closer to achieving our goal?
Sure. Should I just go ahead and take? Yeah, I'll take the question, Abhijit.
Yeah, or I can just add to that, because mine was kind of an variation of that. In that, this whole thing about decolonization, imperialism, the kind of the whole debate on the global north and global south, etc., kind of happening quite a lot in more recent times. And my concern is that a lot of it remains within the four walls of these academic discussions. And you know, every time you go to a meeting, I've just come out of a meeting in London a couple of days back where we had similar discussions with people from different parts of the world about whose power is it to give, whose power is it to take, and all of that. But once we get into the real world, there's nothing happening besides some amount of tokenism. So how do we kind of actually, like a lot of these other things that we kind of work with, how can we really make the change happen? Maybe I'm being a bit impatient, but maybe make it happen quicker than what is happening at the moment, where we think organically over time something will change.
Okay, I hate to tell you, there's no quick solution to this. But let me say something about which things I think could be done sooner and what kind of effects they might have in cascading, hopefully, the struggle against inequality. I think, and if you remember right at the start of my talk, I talked about some of the things that we actually have a lot of evidence for, which is about panels and committees and, you know, the 1090 research problem, you know, all of those kinds of things. I think we can insist that all of that is part of the decolonization, and what exactly does that mean? What that means, now, this is not to say, and I have no belief, that just because you put a brown or black or female or Dalit or whatever face within a committee, you're going to change everything or anything. And there is certainly the challenge of co-optation, which is not minor. I think we have to understand we do have experience on having tried to do this over at least the last 2 decades. And we know much more about how this has to be done in order to ensure both less co-optation and also that people, when they enter into these spaces, don't feel isolated and alone. that they need to be able to feel that there are others like them who will have their back when they, and who will, you know, when the smirks and the laughter, oh, yes, yes, nice girl, or, you know, yes, yes, we understand, you know, where you're coming from. And then you spoke so passionately, you know, meaning thereby you're not scientific or rigorous at all. We know that, but we need consolidated presence to do that. So I think we need to garner and pull together much of the knowledge that we have based on trying to do this over, I would say, at least about a couple of decades, certainly in the context of gender, maybe in the context of race as well. We have that, and we haven't pulled it together. We keep repeating the same mistakes. But having said that, that's the low-hanging fruit. And what is the expectation from doing that? The expectation from doing that is you're bringing people in, and this has to then be built in, because it's not just about bringing people in. It's about changing institutions or creating new institutions that actually address the kinds of challenges that poor and subjugated and subordinated people face. If you're just bringing people in for greater representation without actually changing or creating an institution that's going to address those challenges, it's, you know, a very hit or miss kind of process. I think we have more knowledge in the health field, even from within WHO itself. In doing this, there's a lot to be learned, but what that does then is, through the combination of representation and institution creation and transformation, you get the possibility of opening up these kinds of issues and questions in a way that you wouldn't have been able to otherwise. So I can give you an example. I myself have been involved in something in WHO. WHO's Department of Reproductive Health Research, about 3.5 decades ago, created a gender and rights advisory panel, sitting parallel to their scientific and technical advisory committee. And in the beginning, it was like, oh yeah, that's where the girls go. But over time, that has changed. And it started, and that department is now, you know, very much a fulcrum for a lot of the gender and intersectionality work within WHO, which you won't find in other departments. It's actually quite interesting to see that. So it is possible. It may take, but you know, a couple of decades to come to fruition, but it can come faster if we learn from our experience. The side that's much more difficult is getting at the research. We need to sharpen, and that's why I've been talking about, you know, we need within health to cross over the what you may call subdisciplinary boundaries that keep us from pulling together the different kinds of evidence that now exist. And that's what I was trying to do, to say, hey, there's actually evidence that I can see along 5 different clusters here. And would be very interesting to start pulling some of this together. Because ultimately, I think you cannot address, to address power, you have to in practice address power, which means addressing people, addressing institutions, addressing the work that is done, addressing the hierarchies. just talking about decolonization. And as I said, I completely agree with you. I have, for me, that term is now becoming close to anathema. Don't tell me what that is unless you tell me what you mean by it. But I do think we can leverage the fact that there is that to keep it from staying at the level of just jargon and nonsense to becoming real. But there are some very real challenges, as we know. Let's not forget that the larger socioeconomic challenges of how health funding is, of the world that we live in, are all militating in the other direction. But when has that ever stopped resistance?
True. Thank you, Geeta. Thank you for that response. It gives all of us kind of working in this space some hope to look forward to. So I've got a question in the chat here. It's from Amita, which says, it's clear that we have more inequality and less solidarity. However, philanthropy also seems to be in fashion. Charity is not the same as solidarity, but would love to hear your views on this.
Sorry, I was looking at the Q&A, but I think this is
there in the chat. It's in the chat.
The chat. Look at the question. Charity is not the same as solidarity. Absolutely. Charity is charity. I do it out of the goodness of my heart. Solidarity, I do it because the solidaristic gene is now expressed in me, so to speak, is because I do it because I see in you myself. And that's very different. I don't do it out of the goodness of my heart. I do it because I understand and try very deeply to understand what it must mean to be there. So philanthropy also seems to be, philanthropy is often nothing but charity. And as we know, there's a lot of things that go on in the name of philanthropy. Philanthropy, as has been said, is also philanthrocapitalism. But I do agree with you. It's very different from solidarity, and we have a lot more research evidence on this now than we used to have before.
Thanks,
Sorry,
Geeta.
not sure if I answered that question.
People are warming up now. We've got 3 minutes, and there are 2 questions in the Q&A box. I'll leave it to you whether you'd want to kind of pick one of those or both, but we've got a couple of minutes to go.
Yeah, okay. So actually, I see 3 questions. One from Amar. The rise of polarization internationally and in India, also rise of passions. How do they relate to the inequities in the physical and mental health? Okay, I think that the connections are pretty clear, and that's what I was trying to say. I think there is increasing evidence that that the social polarization is very connected to the obscene increase in economic inequality, and which has been fueled by this period of globalized, liberalized economies, which have in fact enshrined selfishness, greed, and inequality in ways. Capitalism is always about that, but that we haven't seen. I wouldn't say we've never seen before. It's been there before. It was there before in the early 20th century, and it landed us in two world wars. So this is very much, we're seeing, in a sense, almost, I would argue, a repeat of that phenomenon. And if you look at that rise, in that period of the early 20th century, it was very much also connected to the so-called Gilded Age, the huge increase in inequality, the devil take the hindmost, and then, people being left to, so they then, go in every direction. What can we do at individual level? Somebody is asking. Well, what you can do at individual level is focus like a laser on how your own work pays attention to the implications and the context of inequality. Someone asked, what's your opinion on the holy spot as to RCTs? RCTs are actually, that requires a whole other talk, which I don't want to get into right now. But RCTs are one place where the transdisciplinary contamination has gone in the other direction. If the individual, the contamination of Homo economicus, of the individual, has moved from economics into other disciplines, including health, I think RCTs have gone from health to where they're contaminating economics. I would say serves it right, along with others. It has no place. And we know, I think any real researcher, yes, this is definitely part of the colonization, because colonization means only some methods, some ways of approaching evidence is rigorous, is appropriate. And that, of course, automatically and immediately excludes those things that are seen as social or qualitative, more importantly. And everything gets put into if everything gets put into the RCT box, I don't have anything against RCTs, obviously, within a certain limited frame, particularly of testing, testing new drugs. I wouldn't want it done, particularly any other way at this point. But in terms of efficacy and safety, but surely it has to be tested. Otherwise, surely it has to be complemented. And surely there are realms where the RCT has no place at all.
Great. Thank you very much, Geeta. We have overshot our time by a couple of minutes, but I think it was really worth it. And we'd actually lost a few minutes with regards to kind of technical difficulties. So once again, thank you very much for joining us and for this wonderful talk and kind of waiting beyond the time to respond to some of the queries. We look forward to more conversations like this because, as I said, people are warming up now, but unfortunately, we can't kind of go on with the conversation. And there's lots to be discussed and lots to be said around this very, very important issue. But thank you very much once again. We keep saying this. Thank you for joining us despite being unwell. But we truly, truly appreciate the fact that you really made an effort to kind of.
Yeah. Thanks, Abhijit. And thank you, everybody, for good questions. And thank you for the opportunity.
All right. I just need to see a few words to those who have stuck on beyond the time and who have been with us through the whole day. It's been a wonderful day. Thank you for joining us. We've had a whole spectrum of talks which kind of span from high-level theoretical, philosophical thinking to what's happening on the ground and things that we are doing on the ground and the lessons that we learn from them. I guess despite some of the technical difficulties, despite the fact that some of our speakers were not able to join us, despite the fact that some of us were unwell, I think all in all, we did have an wonderful day today. Lots for us to reflect on, lots for us to think about, and maybe some of these issues and some of these conversations we can continue outside of this conference as we build new networks and new relationships. So thank you very much. And we hope that some of you will be joining us in Chennai next week when we have the last part of the conference, which is going to be face-to-face and which is going to be hosted by the Banyan Academy. And yeah, we'll see some of you there. If not, this field is small and the world is small. We'll probably meet each other at some point. Thank you and have a nice evening. Bye-bye.